uh, for affordability. And Morrison's is now with local manufacturing and providing support, able aid to the national government as well. So I would like to have your attention as we have our super platinum sponsor, Morrison's PLC here, and the managing director of the company, Mr. Dinesh Athapattu, to take you through the company's vision and how we can, the Morrison's contribution towards the success of the nation. Mr. Dinesh Athapattu, can I have you on stage, please? And once again, ladies and gentlemen, would like to have your attention towards the screen as well. Thank you.
Thank you. So let me say Aibowan and greet you in our truly Sri Lankan roots and stick to that, being a truly Sri Lankan company. And extremely sorry for hijacking your lunchtime a bit, but I think the program is running behind the schedule, so the organizing committee would like to take this up while you are having lunch. So I think you have seen a video, you are being seen our stall there, and you are seeing on the screen something called Journey Upstream. You must be wondering why a pharma company is trying and coming and going to talk about a journey upstream. So I'm Dinesh Athapattu, I'm the managing director for Morrison. And I'll need about 10 to 15 minutes of your time to talk a bit about this journey upstream. So I think in Sri Lanka, the healthcare is in the news for all the wrong reasons. So you either see one of the drug or a medicine is get failed, and there's a series of news around that, and a lot of cures. And sometimes the industry that we are in, the pharmaceutical, is being named as a mafia also. So and as a company, we believe it should not be the case, because we are here for people, and people depends on medicine at their most vulnerable times. So changing this narrative, we take it as a responsibility, and therefore we name our journey forward as a journey upstream. And not only that, I think there's another reason we are telling this as a journey upstream. If you give your quick attention to this, what is in the screen, just after independence, all the South Asian countries start pharmaceutical manufacturing. That is somewhere in mid-1950s. 7 decades after today, we have India manufacturing 100% of their pharmaceutical within India, and they export 20 billion outside. India is named today as the world pharmacy, and they are the largest supplier for Europe and US. Forget India, look at figures for Bangladesh and Pakistan. Bangladesh manufacture 95% of pharmaceuticals that is required for them, and they export about 3 billion. Pakistan manufactures 70% of what they want and export. And even after 7 decades, today Sri Lanka, we just manufacture 15% of our requirement, and we don't export. And if you drill down a bit about Sri Lankan pharmaceutical industry, we are talking about pharmaceutical market of about $600 million US, and out of which 40% is supplied at government, because we have a very good free healthcare system. And 60% of the market is private, which is the drugs that dispense through pharmacies. And interestingly, out of the figures, in our private market, still only 5% of the requirement is manufactured locally. 95% still we are imported. And if you really go to a pharmacy, and you can see amount of imported products there in a pharmacy shelf. So we thought, as a company, we should change this narrative, and that's why another reason for us to name this journey as a journey upstream. Even after 7 decades, we believe there should be some light end of the tunnel. Quickly, Morrison is not just starting the pharmaceutical manufacturing. I told in 1950s, when Sri Lanka started pharmaceutical manufacturing, we were one of the pioneers to start pharmaceutical manufacturing. And this is how our initial plant looked like at those days. And when you talk about Morrison, I think a lot of people are not associated us as a pharmaceutical manufacturing, but I am sure every Sri Lankan is aware of a Greif mixture and tasted the Greif mixture and apply lactocalamine. So this is what we were known for. But being in the medical fraternity, I think this is something quite familiar to you, a brand called MSJI. This was our business since, even today we do that, but until 2020, 2019, this was our business. We used to manufacture products as bulk, and it goes under one umbrella brand called MSJI. So in 2017-18, we made a call, and I was explained earlier, only the 15% of pharmaceuticals are manufactured in Sri Lanka. Why is that? Sometimes you can talk and blame the policymakers, the policies and all of that, but my belief is as an industry, we also didn't make a progressive step. And that's where we came up with an idea that we need to build pharmaceutical manufacturing capabilities in Sri Lanka. And in that mind, and at that time there were some favorable policies that was coming from the government to supply for government. We invested $20 million investment to build one of the latest pharmaceutical facility right here in Homagama. And at that time, I happened to visit India, Pakistan, and see some of those pharmaceutical manufacturing facilities that they are supplying for Europe and US. And I was shocked. Actually, it was amazing facilities. The standards that they are maintaining are amazing. And for us, a dream was to build similar facility in Sri Lanka. And thanks to that, we have built that facility, and by 2020, we had the facility ready for manufacturing. But what happened in this part of the world is sometimes your government policies are not certain. So there was some change in the policies. There was significant decline on our supplies to government. So it was like 60% decline. And as a result, our investment was really questionable. And at that point, we really wanted to come out with something different. And there we thought, it's not only the government. In the private market, 95% of the products are still imported. And here we have an opportunity to build a credible brand because we have built the manufacturing capabilities to the country. And this is where we started our purpose journey. And actually, if you really look at Sri Lankan healthcare system, we have many challenges as a nation, but one of the biggest challenges are challenge with NCDs. I'm sure you are well aware of this more than me. One out of four people are having diabetes. Cardiovascular risk is increasing rapidly. And for that, there are latest therapies that have been introduced in the world, but the usage of that in Sri Lanka is minimum because of the fact of price. And therefore, before we do the business plans and everything, we came up with the purpose, as we have built the manufacturing capabilities, we should really make a role in making this latest premium healthcare more affordable and taking it to masses, because then people will have access to those and they can live their life up to their full potential. With that in mind, we started building brands, and at Morrison, what we are uniquely or what we are offering to everyone differently. There's no one single factor as such, but what we knew and what we realized is, if we put these 6 factors together as a value blend, as a combination, we can offer that differentiation. It starts with truly Sri Lankan. We are a truly Sri Lankan company, owned by Sri Lankans, managed by Sri Lankans, and we are manufacturing in Sri Lanka. Especially when it comes to management, I would say, we have pharmaceutical manufacturing coming into Sri Lanka, but our general trend is we have a set of expatriates come and start running those facilities. But we took a call. For us in this industry, we have to hear for long haul, so talent development is important. We need to give opportunity to our Sri Lanka. Such a big high-tech plant, I'm sure you have seen some of the footages in previous video. We have only 2 expatriates working, and that is for highly technical areas, and it's run by our young Sri Lankan graduates. We have 120 B.Pharm, BSc Chemistry graduates working with us, and we groom them up in this journey, because for Sri Lanka to go ahead with this kind of a high-tech industry, we need a lot of brain here, and we are working on that. Global quality, I spoke about it. Our facility is compliant for all the global standards. But a lot of people ask me, and especially the medical fraternity, when they visited our plant, they just check, if you are maintaining such a high standards, how you can offer prices at such a low price, how you can offer such low prices. Especially, we are not the most efficient raw material sourcing company. India, China, they can procure raw material at much cheaper prices than us. Our quantities are very minimal. But the fact is, if you manufacture in Sri Lanka, for us, we just manufacture, it goes to a distributor and then to the pharmacy. And when we really study this, we are amazed with some of the margins that some of the international companies are keeping in their regional offices. And in that way, we are becoming very competitive. And our approach is very ethical. From product development to until it comes to market, we don't follow any shortcuts. And our difference that we are really bringing into the table is novel. And you have Sri Lankan manufacturers, usual trend was to manufacture very old age molecules. But we really work on our R&D, and you have seen some of our product portfolio. We have brought the latest therapies to the country, and we are a manufacturer that was in the industry for last 6 decades, and our credibility is not at a question. So with that, we started our brand building journey, and we started our brand building journey with a molecule called empagliflozin, which was a SGLT2 drug. It was very expensive 4 years back. Tablet was not really affordable for average person. And we developed this product in Sri Lanka, and it was matching along with the innovators' resolution profiles. And we offered it at a half of the price, market price at that time. And as a result, what happened is, I think many Sri Lankans start getting access to empagliflozin, which has a lot of benefits. You know it more than me. And as a result, we became number one in that brand. And not only that, all the competitors were compelled to bring their prices down because of our intervention. So here, for us, it's not about becoming number one, but we are happy about the impact that we have created. And as a result, I am sure a lot of Sri Lankan, a lot of diabetes patients and the cardiovascular patients are having access to these latest therapies. And our association and our marketing is all about building partnerships and working with the medical fraternity. We are working with College of Endocrinologists, and we started a series of diabetes program, which is a certificate course which offered CPDs. And now we are working with College of Cardiologists, and of course this association with College of Family Physicians also, we are trying to take it to next level. And this was a proud moment for us, and it's not about becoming the most profitable company or a most highest revenue earning company and being most respected. Because of our interventions, I believe LMD has recognized us as the most respected pharmaceutical company in 2024. And our efforts are continuing. The journey that we started with empagliflozin, recently we entered into the cardiovascular segment with some of the latest therapies again. And we have a cilnidipine, a bisoprolol, and a rivaroxaban. First time manufactured in Sri Lanka and offered at almost half of the price of what is in the market. And ensuring this quality is as same as the innovator, because this is something that we assured. Yeah, and this 10-15 minutes which I used is not to promote our products, but tell our story. And I thought of concluding telling one story. If you ask any Sri Lankan parent or a child what you want to be, I think the answer is to be a doctor. And that's such a prestigious status job. But having said that, I am sure those who in this room know the amount of efforts and the hardship that you are going through in this journey, and the amount of responsibilities that you are carrying when you have to deal with patients. And I don't have first-hand experience, but I have enough of my relatives and friends who are doctors who's gone through that journey. And what I want to conclude saying that how we look at pharmaceutical manufacturing is also something similar. It's not for make money, and it's an immense job that we need to take with a lot of responsibilities. Every drug we produce, every syrup we produce needs to be done with utmost precision, because at the end of the day, there's a patient at the end of the product or a syrup that we manufacture. And that person could be very own our mother, our father, or our kid. So at Morrison, with my team, we are taking that responsibilities. So therefore, don't support us just becoming local, and you don't want to do that. But what I kindly request, when you have an opportunity, make it a point to come and see our facility at Homagama, see in your own eyes how we manufacture, and then trust our products. Because we know you want the best for your patient. Thank you.
Sri Lanka is blessed with natural beauty, abundant resources, a strong heritage, and immense talent. With free education and healthcare, we have much to be proud of. Yet, our nation's reality falls short of this potential. Despite over 60 years of local manufacturing experience, only 5% of private market demand is met locally. Meanwhile, public trust in the industry remains uncertain, when in fact, this is an industry destined to heal lives. So who is responsible? It's easy to point fingers, but doesn't the responsibility lie with all of us? At Morrison, we are conscious that every tablet we produce is trusted by someone at their most vulnerable times. More than just a business, therefore, it's a responsibility we take to heart. Our $18.5 million new state-of-the-art pharma facility isn't just about technology. It's our commitment to making premium healthcare affordable. Welcome to our journey upstream. We believe excellence in pharma manufacturing is built on 3 pillars that need to work hand in hand: compliant facility, product development, and manufacturing process. At Morrison, our facility is a testimony of adopting world-class pharma manufacturing technology. Built as per EU GMP specifications, the design itself prevents cross-contamination through advanced manufacturing equipment with minimum human intervention, and features such as dedicated air handling units, bubble airlock systems, and separate man and material entry. Our chemical and microbiology laboratories comply with WHO GLP guidelines, with every analytical equipment inbuilt with data authenticity and integrity capabilities. However, the design specifications alone won't ensure a compliant facility unless it is maintained consistently as per the right protocols. Therefore, at Morrison, our air handling units operate 24/7. With routine monitoring of key parameters, be it temperature and humidity control, air quality, water purity, or regular calibration and maintenance of machinery. Pharmaceuticals are sensitive products by nature, with no room for compromise as we are dealing with people's lives. During product development, we establish the efficacy and safety of the product we intend to market. Therefore, in our product development journey, we take no shortcuts. With credible technology transfers, careful material selection, robust formulation development, precise analytical testing method development, multiple trials, accelerated and real-time stability testing, and stringent process validation, every step is executed with the utmost care as per regulatory guidelines. A comparative dissolution study with the innovator brand is also performed to benchmark the product quality. The product development process is an expensive investment, which takes a minimum of 1.5 years to release to the market. Although a compliant facility and the right product development are crucial, they are only prerequisites to assure manufacturing excellence during commercial operations. By meticulously following the required manufacturing guidelines, at Morrison, we take full ownership and accountability for every tablet we produce. Our quality management system ensures that every batch that leaves our facility passes through a rigorous series of 20+ tests, including assay, dissolution, impurities, microbiology, and many other physical checks to meet all specifications. Leveraging our advanced manufacturing capabilities, we proudly nurture our very own pharmaceutical brand. built on a value blend that is uniquely unparalleled. With Sri Lankan roots and an understanding of our people, we offer a rare combination of quality and affordability. Our product pipeline is niche and novel, with differentiated branding. Guided by conscience, we ensure integrity across our value chain. Backed by 60+ years of expertise and Hemas Holdings PLC, we aim to boldly challenge import dependency and build the most trusted pharmaceutical brand in Sri Lanka. Across Sri Lanka, brilliant minds are ready to shine. At Morrison, we create a platform for this next generation to lead the way. This is a journey that cannot be made alone or by a few. As Sri Lankans, let us all come together to do our part in the movement of writing a promising new chapter of our nation's legacy to take it to the heights it deserves.
Indeed, making premium healthcare affordable, established in 1939, available in Sri Lanka as a huge contributor for 86 years, and with expertise of 66 years of pharmaceutical manufacturing, the truly Sri Lankan pharmaceutical company, Morrison's PLC, our super platinum partner, and you also can be a part of their journey upstream, as you all can be a contributor to the sovereignty of the nation. And our stall of our super platinum partner is just outside this hall, and you all can visit the stall of Morrison's PLC. So thank you very much once again, ladies and gentlemen. We'll be commencing the next session in 5 minutes time. So I request everybody outside to come in, and also do remain seated for all of you. Thank you very much.
Now, good afternoon. After I think heavy lunch, you don't feel like listening, but still it's a very important session, and it's regarding child and adolescent health in primary care. We got a few speakers. I would like to talk about the first speaker. The topic she is going to talk with you all is a glimpse into clinical genetics for a primary care physician. It's a very interesting topic, and it was delivered by Dr. Vindhya Subasinghe. I would like to introduce Dr. Vindhya. It's my privilege to introduce Dr. Vindhya Subasinghe, Sri Lanka's first board-certified consultant, clinical genetist, currently serving at the Lady Reggio Hospital for Children, Colombo. A graduate of the University of Kelaniya, she trained in pediatrics and clinical genetics in Sri Lanka. She completed her specialist training in clinical genetics at the Birmingham Women's and Children's Hospital, UK. Her clinical interests include rare diseases, dysmorphology, neurogenetics, and skeletal dysplasias. She is also active in research, publications, and international collaborations, and serves as Assistant Secretary of the Sri Lanka College of Pediatricians. Her international collaborations include memberships in UK Skeletal Dysplasia Group, the British Society of Medical Genetics, and the Indian Academy of Medical Genetics. Today, she will deliver her lecture, as I told you earlier, a glimpse into clinical genetics for the primary care physicians. Over to you, Dr. Vindhya, and it's a great pleasure because we know we have another relationship with you. It's our senior lecturer, Dr. Supun's wife. I'm pretty happy to say that. Okay.
Thank you very much, madam, for those kind words of introduction. Good evening, everyone. So I would like to thank the Council and the Scientific Committee of Sri Lanka College of Specialist Family Physicians for inviting me. I consider it a great honor to give this talk today. So as the madam mentioned, the topic for today is a glimpse into clinical genetics for primary care physician. I think it is very timely as clinical genetic services in the Ministry of Health is recently established, and that it's important every physician should be aware what is the usefulness of the clinical genetic services. So during the next 20 to 25 minutes, I'll talk about what is the scope of a clinical geneticist, the importance of knowing the scope of clinical genetics for a primary care physician, when to refer your patients, and at the end, some case scenarios. So first we'll see who is a clinical geneticist. Some people think that clinical geneticist is a qualified person who works in a laboratory. So since I started my journey in clinical genetics way back in 2020 as a post-MD trainee, people, and even now, people ask this question from me: are you working in a university and what are you doing? So, clinical geneticists are medically trained doctors who specialize in genomic conditions, use a combination of medical knowledge and specialist understanding of molecular biology to diagnose and manage range of patients at different stages of life with various clinical presentations. So, what do clinical geneticists exactly do? So, when there is a patient with signs and symptoms and the suspicion of an underlying genetic etiology, we see them. And as for any other patients, it's the same process: history, examination, investigation. But as clinical geneticists, we are particularly interested in family history. A minimum of three generation pedigree is a must for us, but sometimes we might have to go more in detail in the wider family. Then regarding the examination, it's really important that we look at the patients carefully, not to miss any clinical clues towards a diagnosis. So head-to-toe examination plus system examination is important. Then it comes after analyzing all the other investigation that the question comes whether to do genetic testing. So depending on the clinical scenario, we may decide to do genetic testing. It could be diagnostic testing or predictive testing, or sometimes we choose not to do testing. That is depending on, sometimes we have a very clear-cut clinical diagnosis, and on occasions where confirming the diagnosis would not cause any impact to the family or the individual, we would choose not to test. And then comes the management depending on the condition. So there are a few aspects in the management. We could arrange the surveillance for the anticipated complications that comes under prevention, or there are specific therapies. So when it comes to genetics, there are evolving gene therapies coming in, but until such time, there are a lot of things that we can do. If I take one example for epilepsies, for refractory epilepsy is one condition that I'm getting referrals very frequently. So when we know what is the genetic etiology for that, it is really easy for us to change and alter the conventional therapies that we give, and we can transform their lives. Then the next question the individual or the family has: what's the impact of this diagnosis to the family? There it comes the genetic counseling aspect. With that, we need to go more deeper into the family history, their logistics and everything, and offer the individualized plan for each and every family members. So what's the range of people that we see? If I say it is pre-womb to tomb, it's the correct way. So we see premarital couples who are coming for genetic counseling. And when there are people in the family with a genetic diagnosis or previous children affected, the couple, if they don't want to take any recurrence risk, there is the option of pre-implantation genetic testing. So some couples opt to do that. And then there are pregnant ladies who wanted prenatal testing, genetic testing, depending on their indications. For example, it can be advanced maternal age where there is a fear of having a baby with aneuploidy, or it could be some other reason where an anomaly scans have picked up any abnormalities and the obstetrician is suspecting any genetic conditions, etc. And then from pediatric population to geriatric population, with any sort of symptoms and signs, with the suspicion of a genetic etiology, we see them. And even after death of an individual, when the family wants to know what it exactly is, and if they suspect a genetic condition, they wanted more details. So molecular autopsy is the option for that reason. So I think you all will agree that the primary care physician or the family physician also cares more or less similar range of age groups. So I think it is, this highlights the importance of knowing why the genetics is important and when to refer. So moving on to the next bit, when to suspect and when to refer, I would say broadly, any unusual findings in the head-to-toe examination suspecting of a congenital abnormalities needs evaluation. If we start from the head, any difference in the head shape could be a syndromic diagnosis. Any difference in the ear shape or structure. And sometimes subtle differences in the eye may be a clue towards a diagnosis. Sometimes these features might be overlooked. And when it comes to hands and feet, there can be patients with extra fingers, which is polydactyly, or sometimes with joint fingers or toes, which is syndactyly. And then it comes to a dysmorphism. So dysmorphology is one area where a clinical geneticist has specialized in. So as family physicians, I know that you all are familiar with some common syndromes like trisomy 21, where you picked up when the child walks into your clinic. But sometimes, it's not always, sometimes you think that there is something unusual, but you can't pinpoint what exactly it is. So that's where you need the help of a clinical geneticist. And the other common thing that we encounter is unexplained developmental delay or intellectual disability. So as you all know, trisomy 21 being the commonest intellectual disability, but there are other syndromes as well. But when we talk about the dysmorphology, the dysmorphic features varies and they have ethnic diversity. So we don't get the textbook picture in our children always. So I think it is important that we go through our own patients. So this is a patient with intellectual disability. As we talked about the most common cause of intellectual disability as trisomy 21 overall, if we take boys, the commonest cause would be fragile X syndrome. So this is a Sri Lankan patient with fragile X syndrome. So I hope you appreciate the classical facial features, a broad forehead, triangular face, and the large ears, of course, although it is documented in the books as a feature, it's not very peculiar here. Then moving on to the other features, skin, hair, teeth, and nail. Some skin patches are clue towards diagnosis, like scapulae patches. And any difference in the hair, we need to be vigilant. Also, some teeth abnormalities. So it is not the common practice of doctors to asking to see the teeth of the patients. But if you see any differences, it might be a clue towards a diagnosis if they sometimes have other problems as well. So after the clinical picture, having x-rays is important. But what my personal advice is that we take dental x-rays after opinion of a restorative dental surgeon or orthodontic surgeon, and this is an X-ray of one of my patients that I've recently seen, taken after dental opinion. And there could be very striking nail changes, as you can see in the picture, or it can be very mild features where it can easily be missed, like nail hypoplasia. Moving on to the other problems, like there could be postnatal growth failures, and short stature is one important thing. So if I take this family that I've seen, the youngest child in the family was referred to me with the indication of short stature. And mom was not worried at all because she's also short. And when I dig into the family to find out that the other two siblings are also short, as you can appreciate in the picture. And they have a spinal deformity, and it looks like a skeletal dysplasia. So this needs evaluation because they are girls with, we can help them in many ways. And then overgrowth is one other thing. If you see this picture carefully, you see the foot deformities, and this boy had undergone multiple surgeries for leg lengthening without any success. So this is where this child is obviously having an overgrowth, and if we look at the other parts of the body, there's obvious overgrowth, but that has been overlooked and only attended for 13 years. The only interventions had been done for the limbs, lower limbs, but it didn't help that person. So overgrowth syndrome is not going to have a benefit of doing surgeries because they tend to grow without a control. So similar to short stature, tall stature is another indication that we need evaluation. And there are some other reasons, some of them I mentioned already. Family history of genetically confirmed cases. Cancer is one other important thing. So as you all will agree, cancer is becoming an epidemic now. So there are individuals in our society with the increased risk of cancer where there is inherited cancer syndromes where we are not identified properly. So if there is a family you see in your clinical practice with cancers in the more than 2 generations, it's really important that we evaluate them, because we all know that if we picked up a cancer early, it is easy to treat and treatable ones. So individuals who have a potential or identifying inherited cancer syndrome and having them under surveillance would help them. And the other one is a couple with recurrent miscarriages. So recurrent miscarriages is one indication to evaluate for chromosomal rearrangements in the couple. And then, as I mentioned before, premarital couple coming, who might be consanguineous couple coming for genetic counseling. Next, I would like to go through some case histories. All of us would like to listen to stories. So this first case is to show how a simple clinical sign can be a clue towards a diagnosis. So this was a 10-year-old boy referred to me by an eye surgeon with bilateral optic nerve coloboma. Initially, there was a suspicion that it could be Charge syndrome, but didn't have any other features. He was developmentally normal and there were no other health concerns. When I examined him, he had mild ptosis, clinodactylity, that is bilateral curving of the 5th finger, and low set tears. And the parents were not keen on genetic testing at all, but they are well-to-do family. But I didn't feel like leaving him alone. So after convincing, they agreed to do genetic testing, and the whole exome sequencing revealed a genetic variant in a gene called PAX2. So it is related with the PAX2, confirm a genetic diagnosis of PAX2 related papillorenal syndrome or renal coloboma syndrome. So this syndrome, we know that 30 to 40% of individuals will end up in end-stage renal failure. So knowing this diagnosis, he didn't have any renal symptoms at present. So knowing this diagnosis is really important because we could make the life better, either by delaying them going into the end-stage renal failure or having a nephrology follow-up will be helpful for him to get a preemptive renal transplant with a better quality of life. Moving on to the second case to highlight the importance of exploring the information from the wider family. So this boy was referred to me because his father unfortunately died prematurely. So it was a sudden cardiac death at the age of 42 years, and the postmortem suggested that he had hypertrophic cardiomyopathy. So the referrer came to see what is the risk of the children having hypertrophic cardiomyopathy. So when I explored the family history, there were few individuals in the family who had died. Exploring the reasons, it's not cardiomyopathy, they are due to cancers. So mom had a breast cancer, and the two of the siblings, one had brain tumor and the other one had spinal tumor. So it's very striking, that family history, whether this family could have a inherited cancer syndrome. And also moving further in the pedigree, there are other childhood deaths without the cause. We don't know, it could be cancers as well. The maternal side of the family, there's one individual who died of breast cancer. So that is a very isolated case. So you can compare the side of the pedigrees, what is the striking within. This is to highlight the importance of gathering the family history, which is also a possible thing in the primary care setting. Moving on to the third case to highlight that in genetics, it's not always testing. So this is a 5-month-old baby boy who was referred to me again by an ophthalmologist with a diagnosis of bilateral retinoblastoma. When I explored the family history, father had unilateral enucleation done at the age of 6 months for retinoblastoma, but he was completely blind. And I inquired about the other eye. He wasn't sure what's the cause, but I assumed that it could be retinoblastoma as well. And the mother was also blind, but it was due to some other problem where she had retinopathy of prematurity leading to blindness. Going through the family history, so we know that the child has bilateral retinoblastoma and father did as well. And father was a well-educated person. He was in a mind that his problem was due to his parental consanguinity. As you can see in the pedigree, the father's parents, the child's grandparents, were consanguineous. But he was in a dilemma, why my child got retinoblastoma. And there was no other family history of cancers or renal or eye problems. But the main problem here is the poor not having correct information. Actually, they were really worried about the child having the retinoblastoma, and the father was in a real guilt. But I had to say that retinoblastoma is not autosomal recessive. It is nothing to do with your parental consanguinity. And when you have the condition, you have 50% chance of passing into your offsprings. So as a couple, they didn't want their second child to have retinoblastoma. Then I had to go on discussing the reproductive options for them. So one such option that we could have is pre-implantation genetic testing. So before any testing, there's a whole lot of process. It's not the matter of writing the test name and sending them to the lab, because we need, for genetic testing is a lifetime testing. So it needs lots of pre-test counseling. That's all the cases that I'm discussing, and a little bit about the setting for us in Sri Lanka, the laboratory facilities for genetic testing. So these are the list of testing that is available for us at the moment. Unfortunately, only karyotyping is government funded. And there are certain tests that is available at the Center for Genetics and Genomics, Faculty of Medicine, University of Colombo. Again, it is self-funded. Patients has to pay out of pocket. And all the other testing is available in the private sector for a cost. And recently, there is a genetic lab established in the National Cancer Institute, Maharagama, and they are starting testing, and initial stages they've started some hematologic testing. And then for patients who can afford, we have recently got the opportunity to send samples for whole genome sequencing. That is the most advanced technology for genetic testing worldwide. And they have rapid sequencing, ultra-rapid, and blended genome exome sequencing, where the turnaround time of testing would be around 1 to 2 weeks. That's super quick. So regarding the clinical genetic services in the country, we have 3 clinical geneticists functioning. I am at the Led Ridgeway Hospital, and I have my 2 colleagues working in Sirimao Bandaranaike Specialized Children's Hospital, Peradeniya, and National Hospital of Sri Lanka, Colombo. And if I take you through some of the statistics of my general genetics clinic at Led Ridgeway Hospital since I started in January this year. So you can see the amount of patients, although it is a new field. There are a whole lot of case loads, and this is also, there is, I think, more. In addition to the general genetics clinic, I do once a week neurogenetic clinic jointly with the consultant pediatric neurologist, and once a month DMD joint clinic. That is a multidisciplinary clinic. At last but not least, I would like to pay your attention for this article that I saw in Genetics in Medicine journal. This is a study which was done 20 years ago in states. Clinical genetic issues encountered by family physicians. And with this data, it has created a usefulness in organizing the genetic services and planning the professional education programs for primary care clinicians. So, going through our background, having primary care physicians seeing is the focal point of referrals, and where the patients first contact, and having, as a country, having clinical genetics services established very recently, I think it's very timely that we also, as a country, think of doing similar research. I would like to propose it to the Sri Lanka College of Specialist Family Physicians research team. With that, I would like to conclude, and thank you very much for your attention.
Thank you very much, Dr. Vindhya. It's for the very comprehensive and choosing a timely topic. Now it's open for you all to ask some few questions.
Thank you very much, Madam, for that very informative and comprehensive lecture. So I'm coming from Hambantota. So for a child or a patient who is from Hambantota, what is the referral pathway to reach these services?
Yeah, thank you. So Hambantota would be, LRH would be the closest place. If it is a child, so you can refer to Led Ridgeway Hospital. So I have general clinics 3 days a week, and you can call the hospital and get an appointment if it is not an urgent one. But in case it is an urgent one, I suggest the clinicians to call me directly so that I can accommodate them early. So for example, I would say urgent ones would be if there is a couple who wish to have their next pregnancy soon and wanting the diagnosis of an undiagnosed previous child, it would be something urgent that we might have to handle, right? Did I answer your question?
Yes, madam. Thank you very much.
That's with that, of course, I would like to ask, now there are how many agencies we have here? One is in LRH, other one?
Yeah, the other one is at Sirima Bandaranaike Peradeniya Children's Hospital, and there's another one who is awaiting foreign training at National Hospital, Colombo.
So then two are in the Colombo district.
Yeah,
So
that one, madam, actually from adult stream. So they recruit for clinical genetics, they recruit people from MD pediatrics and MD medicine, both.
Okay, so then the only access for us is for the LRH or the to
Yeah,
NHS.
yeah.
Right.
Actually,
okay.
the problem is genetics is not a division in
Yes.
other countries. We have to cater them as families. So there are some adult patients that needs my opinion sometimes. What I would say that there's a problem with the hospital when they come to hospital and they don't register anybody over 16 years. So what I suggest is to add the name of some family members who is even not affected as a proband and to send them. Then I'll usually see the whole family.
Thank you very much for your other answers. Any questions from the audience?
Any more questions?
So in the absence of questions, we'll move on to the next session. Yes.
All right, that concludes the first segment of the Symposium 4, Child and Adolescent Health in Primary Care, and we had Dr. Vindhya Subasinghe talking about a glimpse into clinical genetics for the primary care physician. And it is time that I invite the chairpersons, Dr. Lalanta Senaratne and Dr. Pradeep Gunawardana, to give away the token of appreciation and the certificate to Dr. Vindhya Subasinghe. Thank you very much, Dr. Vindhya Subasinghe, and once again inviting the chairpersons to continue with the Symposium 4.
Our next topic is fostering adolescents' emotional and behavior well-being. It is my privilege to introduce Dr. Darshini Hittiarachi, consultant child and adolescent psychiatrist at the Lady Rich Hospital for Children, Colombo. Dr. Hittiarachi is a board member of the National Child Protection Authority and currently chairs the Child and Adolescent Subcommittee of Sri Lanka College of Psychiatrists. With extensive experience in managing child victims of trauma, her academic contributions include numerous national and international publications on child mental health, covering areas such as dyslexia, autism spectrum disorders, neurodevelopmental comorbidities, and child protection. She has been instrumental in advancing the understanding and management of child abuse victims in Sri Lanka. I warmly welcome Dr. Hittiarachi to speak on the topic, fostering adolescents' emotions and behavioral well-being. Over to you, Dr. Hittiarachi.
Good afternoon, everyone. Thank you, Dr. Pradeep, for that kind introduction. First of all, I would like to thank Sri Lanka College of Specialist Family Physicians for giving me this opportunity. So, fostering adolescent emotional and behavioral well-being. Before thinking of how to support them, I think we need to understand who these interesting creatures are. I mean, as clinicians as well as parents, I think we have a lot of challenges in handling this interesting group of people even at home environment. So let's see who these adolescents are. It's a journey from totally independent child to totally independent adult. According to WHO definition, the age group is from 10 to 19. So for this totally dependent child to become totally independent adult, they have to go through certain developmental tasks like acceptance of change, physical appearance, development of gender role identity, development of cognitive skills and acquisition of knowledge, and develop their own identity, who they are, and development of independence from parents and other adults, and preparing their career, social responsible behavior, and also adjusted to certain social groups, and starting maintaining sexual relationships, strong emotional bonds with another person, that is romantic, and becoming financially independent, developing moral concepts and values, and philosophy of life. So it's not an easy task for them to develop and achieve all these goals throughout this process. So to achieve this, there are certain developmental domains which happen, like physical development, cognitive development, social development, and moral development. If we focus on cognitive development, certain areas like thinking, logical reasoning, problem solving, attention, memory, so there are certain areas that they need to develop. Let's focus on cognitive development. I think those are very basic. We all know that the brain is made of billions of nerve cells, and these nerve cells get interconnected through nerve processes and form neuronal circuits. I think we all are aware that everything what we do is controlled by these nerve circuits. Again, we know that at the birth, the number of nerve cells are static. But as you can see in this picture, by 6 years, there can be various nerve processes, nerve circuits, and various, it's a massive number of nerve circuits and processes are there. But by age 14, the number of nerve circuits and the processes have come down. We call it the pruning process, where, for example, if an individual is getting engaged in a certain activity, then the brain circuits which are responsible for that work will get strengthened. As well as if the individual is not doing some task, then the brain circuits which are responsible for that task will get decayed. So we call it use it or lose it phenomenon. So like that is why we have to focus more in adolescents, more often healthier habits rather than negative things. For example, like if they get involved in video games where like they promote aggression, like firing, shooting, then the brain circuits which are responsible for aggression will get strengthened, and then even they become adults, they are going to have more and more aggression. I think these drug companies, all these people, they are well aware of it. That may be the reason that they are targeting like adolescents. I mean, have we ever heard that some adult being given toffee or substance something? No, they always target the adolescents, because if this adolescent brain get exposed to these things and the nerve circuits get strengthened, then even if they become adults, they are going to have this addictive behavior. And even if we try, sometimes it may be difficult to rehabilitate them. So this age is very vital to decide what kind of a person he is going to be. So that is the synaptic pruning, lose it or use it phenomenon. And the second important point which I want to emphasize is the brain maturation. I think we are all aware brain maturation is the nerves will get myelination, which improve the efficacy of nerve conduction. So this process occurs from back part of the brain to front part of the brain. Many studies have shown usually the maturation of front part of the brain completed by age 21, but some studies say even it goes up to 25. So what are the main responsibilities of frontal lobe or the frontal cortex? The impulse control, judgment, problem solving, emotional processing and self-control, language, organization, motivation, goal setting, behaviors. So I think now you can understand. So in these special creatures, the emotional brain is well developed, but the thinking brain or the frontal lobe is still developing. So it's easy for us to understand that most of the time their activities are very much emotionally driven and very much less logical thinking. They do various things without even thinking the consequences. So I like to compare this teen brain or an adolescent to a brand new car, full option, driver with high energy but without brake. So it's like big engine, matured body, independence driving, and poor driver, immature prefrontal cortex and judgment. It's like faulty brake system. And yeah, immature inhibitory mechanism and high octane, that is high hormone level. What does that mean? There is high risk of getting accidents. I mean, we can predict. They are always, predictably unpredictable. The things what they do is most of the time predictably unpredictable. I mean, if I have time, I would give you so many clinical examples where they have got into trouble with various things without even thinking the consequences. So it's very challenging. Sometimes this individual go out from the home with a very, very calm, quiet way, but we might hear a disaster within couple of hours because they are predictably unpredictable. And these challenges, usually as I mentioned earlier, the age group is 10 to 19. They start peaking up, these challenges, by 13 to 16 and gradually start coming down by age 19. So you can see the most challenging age group is 13 to 16. So need to be aware this brain is still under construction. That is why they behave like this. So what are the adolescent changes across cultures? Increased novelty seeking. They always want to do new things, experiment new things, and increase risk taking. They don't even think about what can happen. If you could recall, couple of maybe 6-7 months ago, there was an accident which happened near the Parliament ground. There was one youth. He was driving the car 200 kilometers, very fast driving, and it ended up dying 3 people on the spot. But it's impulsivity and risk-taking behaviors. They were not having any mental health issues, but the nature of their age, and the brain is still under construction. And social affiliation shift towards peer-based interaction. I mean, if you have an adolescent at home, or if you are dealing with any adolescent, you may well aware that they can be manipulated very easily by the friends. They will not listen to the parents, teachers, doctors, no one. But if a friend asks him to jump out from a building, they might do it without even thinking. So it's their nature. So they are, by nature, they are very confused group of people. I want to ask this question from the audience: are they confused, or are we confused as adults? Because in certain instances, we tend to make them more confused. For example, like when they do something, some kind of a mature thing, we tend to say, no, you are not mature enough to do this. Vice versa. If they do some kind of a childish thing, we tend to say, no, now you are not that young, you are a mature boy, you are a mature girl, you shouldn't be doing this. So likewise, as adults, parents, teachers, we also make them more confused. Now I think you have better understanding who this group of people are. Now let's move on to the mental health issues that they face. What I want to emphasize in this slide is, as you can see, majority of these conditions are not mental illnesses. Only a small component is the mental health disorders. Other things are mental health challenges. However, we need to identify these problems and need to support them. So what are the mental health challenges? Problems related to physical challenges, They do not like to be different. They always want to get connected to their group. So we know that this pubertal changes, it's a kind of a range. Some people go to puberty at early age. Some people go to puberty at late age. So that differences in physical appearances can be distressing for them. And emotional changes. They struggle with self-esteem, self-confidence, self-image. They just pretend that they know everything. They are very confident. But in their inner mind, they are they have very low self-esteem, self-confidence. That may be the one reason that they can be very easily manipulated by their peers. And problems in social relationships, peer relationships, romantic relationships. I think now it has become a trend to have very short-lasting relationships in this young group. It's like sometimes I have seen 14-year-old, 15-year-old girl already have had maybe 4-5 romantic relationships. They last 2 weeks, 3 weeks, likewise. It's commonly happening. And poor social skills. Even though, as I mentioned earlier, they may pretend that they are they are very competent in talking in front of people, they can have friends, but they are inside they are very much weak in their social skills. And due to hormonal changes, they can have certain behavioral problems like, poor anger control. It's not an illness, but sometimes this poor anger control can get them to trouble. And aggression, impulsivity. And I don't think I have to talk about the educational problems our kids are facing, and bullying and abuse. Bullying is very commonly happening, and we always try to sweep it under the carpet. Even so, it's a myth that we tend to believe that we try to normalize the bullying. We say, no, it's okay for boys to be bullied. If you're a boy, you should be strong enough to face bullying. No, whenever we see bullying, globally, it says that bullying should not be accepted because it can lead to various mental health issues in adolescence. Even it can lead to long-term mental health issues as well. And substance-related problems. As I mentioned earlier, always these people these substance sellers, they tend to target this age group. So they are at high risk. And screen addiction and unsafe sexualized behaviors. Again, this has become a very kind of a common problem among our children. One reason is they are lacking the adequate knowledge on safe sex, or they do not have proper sexual health knowledge. And let's move on to the mental health disorders. Attention deficit hyperactivity disorder, anxiety, depression, eating disorders, self-injurious behaviors, and psychiatric illnesses like bipolar affective disorder, schizophrenia. But what I wanted to highlight is actually majority of these presentations are not psychiatric conditions or illnesses, but majority are mental health problems. Still, we have to support them. What are the global data on mental health issues in adolescence? WHO report 2024, globally 1 in 7 10 to 19-year-olds experience a mental disorder. And depression, anxiety and behavioral disorders are the commonest. Suicide is the third leading cause of death among age 15 to 29. And what are the national data? The Global School-Based Student Health Survey Sri Lanka, done in 2024 by Ministry of Health, according to this data, their data, 18% of students having depressive symptoms in our school population, 22% feeling lonely, 7.5% not having a close friends. These are risk factors for kind of suicidal behaviors and risk-taking behaviors. And 15% of students experience suicidal ideas. 36% had faced extreme distress, and out of that, interestingly, only 2.1% of students sought help from adolescent mental health services. So they are having very low help-seeking behavior. There may be various reasons. Maybe they are not aware about the services, or they may not trust anyone to come and ask help. There are various reasons, but anyway, their help-seeking behavior is very much low. And prevalence of substance use among school children also have increased compared to previous studies. So I think now you have some understanding about the challenges, what they face, the common mental health issues, and the nature of this problem and how the condition is getting worse. Now let's see what is the place of primary care physician in helping these adolescents. I think the most important thing is that they may not come with clear mental health problems. They will come to your practice with some other problems. And usually the adolescents, parents, they are very close to their family physician. They tend to share their difficulties with the family physician. So if you are aware about these problems, then it will be easy for you to be the bridge between the patient and direct them to the mental health services. For that, it's important for you to have some understanding about the early warning signs of adolescent mental health issues. They will not come directly. Most of the time they will come for some other thing, and when you talk to the child, then only you will realize there's something more than this is happening in this child. Persistent changes in mood, behavior and social habits such as prolonged sadness or anger. The child might say, "Doctor, uncle, I don't feel happy like earlier." Because they have a good rapport with their family physician. And mood swings. The parents might say, one day they are very happy, the other day very sad, always at the edge. And irritability, get angry very easily, sometimes tend to break stuff at home, sometimes even shouting, screaming, yelling at parents. So irritability. Withdrawn from friends and activities. Sometimes the parent might say, my child used to do lot of extracurricular activities, but now he is not having any interest on doing anything. So it can be an alarming sign that whether this individual is suffering from mental health issues. And declining academic performance. Again, because when you talk to the parent or the child, they might say, usually if they are coming to see their family physician, they have a good rapport. They tend to talk about their achievements, their failures. So there you can identify these issues. And drastic changes in eating or sleeping patterns and excessive worries, lack of interest in one's enjoyable hobbies and becoming fatigued easily. It can be a feature of depression, but one thing which I want to highlight is, here I did not focus on mental illnesses mainly, but adolescents who are having depression, majority can present as atypical depression, where they do not have clear diagnostic features of depression, but they come with non-specific features, maybe fatigue, maybe irritability. Likewise, another common presentation may be medically unexplained somatic symptoms. So, it may be one of the commonest presentations to primary care physicians, where they will come with multiple somatic. They may come with headache, abdominal pain, various somatic symptoms, but you do all the investigations and everything is normal, still the individual is having symptoms. Then it's better for you to be alarmed and discuss with the family whether they are happy to seek help. And self-harming thoughts of suicide. If any adolescent discuss or talk about self-harming or suicide, we can never take it for granted. I think we have to pay adequate attention for that. So, what are the support? How to support adolescents? One thing, promote mental health awareness. It's important for these adolescents to know about the mental health issues that this age group is facing. And also it's important for the parents to be aware about the mental health issues at this age, because most of the parents still having very limited knowledge about the mental health issues their children are having. And also they are lacking parenting skills how to support. They always, the emotional availability, that connectedness is lacking in most parents. When we ask the parents to get close to the children, usually what they say, no, we spend time with them. They usually talk to them and say, do you have a problem? Just tell me. I think it will not be the best way to get closer to them. It has to be provide some safe place and say, if I am there for you, if you have any issue, you better come and talk to me. Otherwise, I will be there for you. If you need any support, you can come and talk to me. And second thing is identifying the early warning signs. Then if we can identify early warning signs, then it's easy to refer them to the relevant services. And encourage healthy habits. I think at the primary care physician's level, we can encourage the adolescents to have good healthy habits, good sleep. Because adequate minimum 5 to 6 hours sleep is very important for good psychological well-being. We always encourage adolescents to have a good sleep because there are many individuals who come with poor sleep. They have very irregular sleep pattern with this screen addiction and various things. I have seen many individuals, sometimes they go to bed around 2 o'clock, 3 o'clock in the morning, which is very unhealthy for their brain development as well as psychological well-being. And also, it can affect their memory, no matter what amount they study during the daytime. If they do not have a proper sleep, then it will not be deposited in their long-term memory. So it's very important to emphasize the importance of good sleep and the balanced diet and importance of regular exercises. Definitely regular exercises, half an hour to 1 hour, will improve their physical health as well as mental health. And it's important to discuss with them about the screen time as well, because we see many adolescents using excessive screen time. To teach them about the excessive screen time, I think we have to be aware about what is the recommended time. There, I think, according to the International Academy of Child and Adolescent Psychiatry, and they recommend, if the child is less than 18 months, child shouldn't have access to any screen. If the child is 2 to 5 years, maximum half an hour to 1 hour. If the child is more than 1 hour, 5 years, they do not recommend in particular time, but we usually advise it has to be less than 1 hour unless the child engage in any academic work. So again, it's important to discuss it about the substances, negative impact of substances. I think primary care physicians are the best people to educate them about the importance of not using substances and help them to identify their own emotions and foster open communication and more listening. So finally, I would like to focus on these helplines also. If you feel any individual is having any mental health issue, they might not happy to go to see a psychiatrist straight away, and you may also have doubts. So I think the best thing is to encourage them to contact this mental health helpline, National Mental Health Helpline number 1926. It's working 24/7, and always a well-trained nursing officer will answer the call. They are always working under consultant psychiatrist. And second line is the National Mental Health Helpline WhatsApp. It's a chat line. Number is note 7 44441926. Usually adolescents find this more attractive because they usually don't like to talk. They always ask whether they can chat with someone. So they like this more than 1926. And also, if any individual is having mental health issues, they can contact Sumitrayo, which works from 9 a.m. to 8 p.m. So, I think it comes to the end of my presentation. Thank you very much, everyone, for listening to me. I wonder whether I have time to answer the questions.
Thank you, Dr. Darshini. It's a very nice and very interesting lecture, very informative. Yes, if you have any questions.
First of all, thank you, madam, for the wonderful lecture. If a parent, suppose I had suicidal thoughts growing up, would that be a big chance for my child to also have suicidal thoughts?
Well, I mean, if a parent is harboring suicidal ideas, first thing that person needs help, because there is a high risk to the child as well, because there can be homicide as well as suicide. Especially parents, if they are harboring suicidal ideas, there is high risk to the child. There can be incidents where they can harm the child and then end their lives. So if anybody is harboring suicidal ideas, I think it's very important to get professional support. And also, if somebody is, as you are asking, if the mother or father is always talking about suicidal ideas in front of the child, it can definitely affect the child's mental health, coping. Then child will also learn that expressing suicidal ideas can be a way of coping the distress. Did I answer the question?
Question was specifically, genetically, if a parent was suicidal during, I was suicidal as a teenager. Is there a genetical correlation?
Yes,
Not like now, but when I was a kid.
Yes. So this suicidal risk also explained as a biopsychosocial model. So there can be genetic, psychological and social factors. So definitely suicidal risk comes in families. So there is a risk.
One more question, just a simple one. We come across a lot of adolescents. The presentation is just somatic ones. Fortunately, we have a section in adolescent health. Our teachers is there, Professor Nandani. She has a nice book, and our approach is HEADS approach. We come across a lot of people with some kind of, as you described, ultimately the problem is definitely a psychological issue, though they come with somatic symptoms, mainly the headaches, the majority headaches, abdominal pain and all sort of things. But once we take all the patients, now you gave the Sumitra the thing, but can't we have a chat before we send these patients? Because we give some kind of information we gather from patients with them? Is it a possible thing?
Yeah, I think even with 1926, you can directly contact the staff and you can give a briefing before they contact. I think you can do it.
I think that's the most important, because otherwise, again, they don't, the adolescents, they don't want to repeat the same thing again and again. So if we have all the information with us, definitely we can share with them, I suppose.
I think so, because they are interconnected, this 1926 and the chat line. So maybe you can talk to them and you can WhatsApp the message that you want to convey. Then they can be prepared and answer the adolescent.
Yes.
I think you can do it that way.
Okay, thank you. So in the absence of the other questions, we will
if I have 1 minute, maybe I can give a brief overview about the child and mental health services available in the country. So then they can do the reference.
Yeah, it's good.
So at the moment in Sri Lanka, we have 7 child and adolescent psychiatrists, 3 at Lady Ridgeway Hospital, 1 at National Institute of Mental Health, 1 at Ragama, 1 at Kalubovila and 1 at Kandy. So, but in all the other areas, all the base hospitals above, there are consultant psychiatrists who are conducting adolescent psychiatric clinic. So, if you have any doubt that any individual has to be seen, you can definitely send to an adolescent clinic under general psychiatrist. Otherwise, if you want them to be seen by a child and adolescent psychiatrist, then you can do the referrals to the hospitals which I mentioned earlier.
Thank you. But the thing is, now actually I'm working in Humagam Hospital where there's a psychiatrist, but the problem is with the parents and the children, they don't want to go to the psychiatric clinic. That's why I asked this question.
Well, I mean, it's a huge problem because always when it comes to psychiatry, it carries stigma and discrimination. So no one likes to go to a psychiatrist. It's a huge challenge. I think, we need to have a broad discussion maybe, and we have to liaise with family physicians, because if we can meet them once and have a diagnostic formulation and management plan with the family physicians and continue it, because I have given many medications to many children through parents where they have given the medication through the family physician. They just do a blood test and say your hemoglobin is low, so you have to take this kind of thing, and we have given medications covertly like that. It is a huge problem actually. Thank you.
Madam, please remain on stage. And ladies and gentlemen, that concluded the Symposium 4 with Dr. Darshini Hettiarachchi, Consultant Child and Adolescent Psychiatrist at LRH. And I kindly request the chairpersons, Dr. Lalanta Senaratna and Dr. Pradeep Gunawardana, to give away the token of appreciation and the certificate to Dr. Darshini Hettiarachchi. Thank you very much. So that concludes the Symposium 4, and I invite Dr. Hirantini De Silva, who serves as a specialist family physician in Sri Lanka and as a specialist GP in Australia, and she also serves as a visiting lecturer at the Postgraduate Institute of Medicine and the Faculty of Medicine, University of Moratuwa, to introduce our next speaker, that is Professor Hiran Amarsekara. So the next lecture will be about AI-powered primary care, practical tools for enhanced patient care and clinical efficiency. Ladies and gentlemen, Dr. Hiran Tinidi Silva, to read the citation of our next speaker.
AI-powered primary care, practical tools for enhanced patient care and clinical efficiency. Our speaker today for this lecture is Professor Hiran Amarasekara, Professor in Forestry and Environmental Science. So it is my great pleasure to introduce Professor Hiran Amarasekara, the Professor in Forestry and Environmental Science and Director of Digital Media at the University of Sri Jayawardhanapura. Professor Amarasekara holds a BSc from the University of Jayawardhanapura and a PhD from Bangor University, UK. He is also a Fellow of the Institute of Biology and a Commonwealth Fellow, UK. With over 3 decades of experience in teaching, research and training, Professor Amarasekara is a pioneer in advancing artificial intelligence literacy in Sri Lanka. He has conducted workshops across universities, schools, corporate organizations and healthcare institutions, making AI practical, accessible and relevant. He is also the founder of the AI Skills Hub and the creator of the innovative RCT plus Q prompting framework. As a popular science communicator with a strong presence on social media, his efforts to bridge technology with education, healthcare, and business are widely recognized. Today, he joins us for an engaging session on artificial intelligence for a smarter future, insights, and applications. Let's welcome Professor Hiran Amarasekara.
Right, good evening. So, in a forum with all the doctors, I have come here to tell you about artificial intelligence. Due to artificial intelligence, some jobs are lost, some jobs are created. My job is newly created job. Otherwise, I wouldn't be able to come here to address family physicians like you. The other one is all jobs will be changed. That is why I come here to tell you your job may not be lost because you have MBBS degree and various prestigious degrees, no? So you are safe, however, you have to change with the advent of artificial intelligence. In my generation, I have seen the advent of various technologies over the years. Bill Gates founded Microsoft in 1975. We have seen Windows 3.1. How many of you have seen Windows 3.1? The Windows 95. Windows 95. You have come from Windows 95 generation. Then came, I was studying in Sri Lanka at that time. Then I went to University of Wales, Bangor. In fact, I did, then people asked some of my students who are medical, at that time he came for my biology classes, how come you're a biologist now doing on AI? In university, I did biology with physics and mathematics. Then we had some programming. At that time, we have a BBC computers and Fortran, things like that. Then I went to UK during this time. My PhD was about 50% and 50% was not AI at that time, not in internet is a very primitive stage. But I had some Indian friends and we got together and doing hacking, cracking. I have self-learned everything, not single one I have learned from Sri Lankan. I was at a website at that time called Student Lanka, one of the pioneering sites. I launched that one before Google launched. Then Facebook launched in 2004. At that time, Sri Lanka, there was a social media called Hi-Fi. How many of you have got accounts in Hi-Fi? Now Facebook launched and then Twitter. Then Steve Jobs launched iPhone in 2007. How many of you have had iPhone 1? iPhone 1 තිබිච්ච හිටියද? ඒ කාලේ කවුරුත් ගත්තේ නෑ මං විතරයි ගත්තේ. Maybe some other people also bought, but Then I was witnessing all these things, and however, in Sri Lanka, we have failed in various revolutions, including the digital revolution. In 2022, November, Sam Altman launched ChatGPT 3.5. I thought that this would be another revolutionary step. Then that is why I have started creating videos in order to educate our younger generation, not only young and old, because this is lifelong learning. How many of you have used ChatGPT even once? You know, it's good. How many of you are using ChatGPT every day? Every day, not for your personal use, personal and work use. Few people. How many of you are using ChatGPT for your work? That means patient work and like AI assistant as a doctor. Quite a few. This is dangerous. Not dangerous. I mean, right. I thought medical in Sri Lanka also, we are late adapters. I'm not sure about the medical field, but in most of the fields in our Sri Lanka, we have missed even the digital revolution. That is why our students or our people are first in the list on searching that particular word on Google. It is not because of they are very sexual, but they don't know how to search. Especially, I think when I was in UK, when I go to doctor, they will consult some books, maybe in internet, and give you some advice. But in here, I think in doctors, they don't refer notes. They are always this old medical, maybe you are refreshing with this kind of symposia, but in the medical college knowledge, they are used. So we missed the early internet wave, but we should not miss this AI revolution. So I know that in your work, you have various challenges. As a physician, you get a lot of patients in Sri Lanka, and there's a growing patient demand, and also there's administrative burden. So AI can be used as your assistant and not as a replacement. So that is why I have come here to tell you, you can use this one effectively as an assistant. This is called AI assistant or AI augmented doctors. First, I will tell you two things here today. One is on prompting, other one is on tools. And I am introducing 3 tools which I have developed, not 2 tools. One is talking to ChatGPT or other search, other chatbots are very important. Sam Altman himself said, CEO of OpenAI said, young people and old people are using ChatGPT in 2 different ways. Old people use this one as a search engine, like what is the capital city of Brazil, things like that. But in young people and the experienced people use this one as an operating system. That means like an AI assistant from the morning to the afternoon, they are with the ChatGPT. And last year, the most first use case of the ChatGPT was finding information or brainstorming. But this year, Harvard study said it is companionship. Whether just you have said no companionship, they are asking their mental health from the, because this non-judgmental, no, it is, AI is trained to do this one, not that it is very, very polite or something, but it is very nice, good. If you tell this, your family or the friend, it will make the things very complicated, like romantic things like that. But if you have to trust it, it will give not a correct advice, but correct looking advice. It seems overwhelmed, so the young generation will grab it, and they don't have any friends, so their friend is chatty. So you have to, in the computer terminology, we say garbage in, garbage out. Most of the people do not know how to prompt. It is very dangerous to have a very simple prompts. You have to have prompting structure and give a better prompt to get a good answer. If you just ask, tell me about diabetes treatment, very generic. I can ask, patient can ask, you can ask also. Better prompt will act as a family medicine specialist with 25 years of experience. Or if you can if I can, you can act as a Aristotle, anything. Then you can get AI specific, actionable, clinical response. There are various frameworks, but I will introduce here 4-step framework: role, action, context, question. This is very essential if you are dealing with the patients or any matter. Role is define the AI's medical experience. AI is very intelligent. However, it has expertise on history, medicine, personal relationship, everything. So you have to say role, act as, or you are a family physician, expert family physician. Then action, specify what you really want. Then the context is very important. If you have, you have to say provide medical details as much as possible. Then it knows, then you have to train, because if you know some assistant, they know you, who you are a consultant or normal doctor, but AI doesn't know. So you have to tell it. Then another very important one is ask AI to clarify information. Ask me clarifying questions before answering questions. These 4 are essential. However, new models like ChatGPT-5 are called reasoning models. Earlier models, when you ask a question, it will instantly give you answer. As you can see, the new model, sometimes you can say thinking model. It thinks sometimes 30 minutes, 20 minutes, 5 minutes, it thinks. Then reasoning, you can say show step-by-step clinical thinking. Then it will go step-by-step. Sometimes you can see it is going step-by-step. Confidence, rate confidence levels 1 to 10 scale. Whether I should recommend this medicine, 1 to 10 scale. What is the confidence level? Then you can guess it. You cannot even guess it, you can, then you know what is the AI's level. Then alternatives, provide backup options. So this works because it is a structured approach and it ensures comprehensive output. So this is one example. Role, act as family medicine specialist with your expertise. Action, analyze, create, review specific clinical task. Context, patient details, clinical setting, constraints. Question, ask me clarifying questions for accuracy. You can enhance GPT-5 questioning models. You can say reasoning, show step-by-step reasoning, confidence, then provide backup options. So like this kind of thing, you can say family medicine specialist. Write a SOAP note. I don't know whether you are still using subject-object assessment, this kind of note. So this is a prompting, very important. For a short time, I can't say more. This is at least go and check prompting methods. This is very important. Don't write very vague prompts. The blanks will be filled by ChatGPT. It is very dangerous because it doesn't know, it will assume. It will assume in, the other one is they hallucinate. They are trained to answer. It doesn't say I don't know. It will say something that is more dangerous. So don't tell, you can tell, don't tell me unnecessary thing. If you don't know, tell me I don't know. So it is, you can say critical evaluate, then it will sometimes critical evaluate you. Then other one is ChatGPT. How many of you use Claude AI? For academics, work-related issues all over the world, they are using Claude. So if you are switching from ChatGPT to Claude, you will instantly see the difference. How many of you have got any of the tools? Paid models, not the free version, $20 paid models. Very few. For the that is the other problem. The free version don't have any security. So if you have money, I know that in Sri Lanka, $20 is much, but for the doctors, what is this? So if I have spent firstly on Claude. Claude is fantastic model. It is good for various things. But on the other hand, ChatGPT is a very famous model, but it is for general purpose, but for the academic work. And also the English also very, if you write in ChatGPT, instantly you can see this is written in ChatGPT. Our students sometimes write ChatGPT. If they switch to Claude, it is difficult. I think higher education is the biggest one because we have changed a lot of things because students are copying from the ChatGPT. Professors are trying to detect them, use AI detectors. It's a cat and mouse game. No one is doing anything. Other one is Perplexity. How many of you use Perplexity? Perplexity. Don't use Google. I mean, you can use Google. It gives the blue links and all the first links are advertising links. But if you want to check a medicine, if you want to check this one with the reference, it has Perplexity gives good one. I heard that if you are buying from the PayPal, Perplexity gives $20 one month subscription. So after 12 months, you can switch to another version. But Perplexity is also a very fantastic tool. It is giving with the sources. I am going to give you 3 tools, which is developed by me 5-10 minutes time. That means you can also develop with a small knowledge. This is Claude. This tool, this first tool in a Claude, which is called Claude Artifacts. If you have a Claude paid model, anyone can have a Claude Projects. And a Claude Projects is a fantastic one. ChatGPT also has. You can learn it. You can teach it. Rather than having a normal one, you can put all your, if you want, you can put all medical books. Or, I mean, medical books, he knows. He has read this one. All the things they have read. You have read in the medical school, no? These people, they have read more than you. Medical books, no, nothing. But you can say, but this particular book, right. So this one, it will produce SOAP, Subjective Objective Assessment Plan Note. I don't know whether you are using in Sri Lanka. ChatGPT told me that Claude told me this is a method. I said, I don't know, these doctors are using this one. But then I asked few doctors, they say, it is the way to do. Then clinical case summarization, referral letter drafting. I click this one, I can go to the online, then but I have given 25 minutes. So then therefore I have created a video on how to use this one. So this will, like a patient, I don't know about these patients, Sunil Pereira, 58 males, routine diabetes, all these things are there. You must be knowing this one. No? This is a made-up patient by Claude. Right, so that I will enter this particular tool, age 58, male. While he is waiting, you can type this one, right? You can say, I am using a new tool, right? This is a fantastic tool. Then, right, I will play this video, a demonstration.
This is Family Practice AI Assistant Claude Artifact. So we enter the data. Patient name is Sunil Pereira, age 58, male. The routine diabetes, type 2 diabetes, metformin, then penicillin.
Allergy.
Now you can say generate registration.
You can now register
summary.
the patient.
So it has
register the patient.
Information, vital signs. This is the prompt we have used: role, task, context, question. Role, task, context, question. Now we can say prescription.
Now we can get a prescription. I don't know whether check whether is it correct.
Prescription draft. This is the prompt, role.
It has not given a prescription yet.
Context, medication. What specific
medication?
symptoms?
I don't know.
Then we can say investigation, suggest investigations. So it suggests these routine screening,
lipid profile,
specific presentation, cost effective. This is the prompt use: role, task, context, question.
So this is the first tool I have prepared, but any of you can prepare this one. This is your domain knowledge, so with that one. So that is called Claude Artifact. Then other one is in the ChatGPT, there's what is known as custom GPT. How many of, I don't know whether you have created custom GPT or used custom GPTs. To create custom GPT, you need a paid account. So I have prepared this custom GPT called Clinical Workflow Demo, but custom GPT, due to the safety reasons, they don't allow me to give you a copy. Therefore, I have again prepared another video on this custom GPT. This is that custom GPT in action. on the left-hand side of the custom GPT, they are called GPTs. So in the GPTs, you can select this one. I have created other custom GPTs as well, humanizer and our molecular biology one. Then there is another custom GPT. This is clinical workflow demo for GPT training.
Used only by Hiranamarasekara education demo tool. You can put this here. Register new patient, male, 45, allergy to penicillin, history of hypertension. So this is a patient record, name, allergies, post-medical condition. Would you like me to set up a baseline, vitals, lab checklist?
So lab checklist, it is preparing lab checklist. Based on that data I have given.
Lab checklist. Vitals record, blood pressure, heart rate, temperature, respiratory saturation, baseline laboratory investigation, full blood count, fasting blood sugar, serum creatine, urea function. So these are the tests. Would you like me to also to prepare long-term follow-up template for this patient? Yes. Then this long-term
This is the follow-up plan for the patient. You can give that one to the patient.
Frequency every 3 months each.
You can WhatsApp to
patient
him.
education points, reduce salt intake, maintain regular exercise, avoid smoking, red flag symptom, chest pain, no pressure. Would you like me to start a prescription template? And say yes.
This is start a prescription template.
So it is giving draft prescription. Paracetamol, monitoring. Would you like me to prepare a patient education leaflet? Yes.
So it is giving patient education leaflet also. That is also you can share with the patient.
So it has prepared.
It's in Sinhala as well.
Leaflet in English, simple language, and also in Sinhala. Structure, follow-up, calendar. Zero months, 1 month, 3 months, 6 months, 9 months, 12 months. Ready to use summary sheet.
So all these things can be created, and you can also
This is the summary sheet for this particular patient.
custom GPT.
Registration, baseline checklist, draft prescription, patient education in English, Sinhala, structured follow-up.
Right. So that is what I said, that even another paid tool is a paid tool, but however, if you have a paid tools, you can use this one for your day-to-day clinical practice. Third tool is Perplexity. This is evidence-based medicine. You can always follow. If you want, you can give to the patient also. This is evidence-based medicine. I am giving this medicine based on these sources, and then maybe some patients are very knowledgeable. No, you might as well send it, and you get more patients. Right. But however, I think what is most important is what not to share with the AI. That is very dangerous. I have seen in Sri Lanka, last week I went to Army and Air Force, several companies. They listen, but they don't follow. I'm not sure how this country will go. But please don't share patient's name, ages, all these things to ChatGPT. Someone might say, you will share that Siripala's medical history, and Siripala will check. Someone will ask, what is Siripala's problems? They say he have a chronic kidney disease. All these things come up. Sam Altman, he has said, like in talking to doctor and lawyer is a personal relationship. You can't, court cannot get the details. However, ChatGPT has to provide that details. Therefore, it is very important that one is hallucination. AI confidently provide incorrect medical information. They have to be very vigilant on that one. Don't rely completely on AI data. privacy can never input patient identities, use anomalized data. Siripalta dayawati කියලා හරි දයාවති කියන්න බෑ. සිරිසේන කියලා හරි දාන්න. Clinical judgment, AI suggests, doctor decides. AI is not a doctor. Maintain clinical oversight always. Don't put unnecessarily you might be bias and accuracy. AI is trained on specific populations, may not reflect Sri Lankan patient diversities. That is why you need to give your own context. So it is responsible implementation is very important. Start with administration task first. මේක හරියට අඬුව ලැබුණා වගේ එක එක තලන්න එපා කපා ගන්නවා. Therefore you have to use it wisely. First start slowly. Do with the administrative work, then go with the clinical. Use AI efficiently but not final decisions. Maintain verification protocols. Train staff on proper usage. It is very important, like in the government hospitals, companies. Now the Dialogue has implemented AI agent. Now I know the Dialogue has a rule. Every staff should not use anything other than they have a homemade Dialogue GPT, only use that one. Like that kind of thing should be very essential. Documentation requirement, record with AI assist for the clinical decision. Continuously you learn. So the quick wins, you can start with administrative tasks, then you can go for the clinical support. Then you can actually, week 3, you can actually integrate in your workflow. Start simple, verify everything, then scale gradually. So AI has a lot to learn, but what I have given is a basic thing, what you can do and cannot do. AI is developing every day. Therefore, if you want to learn more, you are invited to join my WhatsApp channel and also Facebook, where I post not on medical, very dangerous domain to post because doctors are, Steve Jobs have said, no, should not tell that one. There are few jobs are remaining, all other jobs are at risk in the future with the AI. AI is developing very fast. That is why you have to get assistance from the AI. Thank you.
Thank you very much for that very informative and practical lecture. And I'm sure as doctors, we listen to a lot of practical information. Professor Amarasekara, would you come back to the stage, please? Are there any questions from the audience? I would like to ask a question. Are there any tools for transcribing or scribing on medical records?
Yeah, there are specialized tools developed by Google and various other companies, specialized tools for doctors. That is what I said that in future this will be your profession will change. However, what I have given is normal general tools, even ChatGPT, Claude. Recently, the Claude, there was American judgment. They were fined. One time they asked, how did you learn? Then the Claude said, they have purchased the books and scanned and then destroyed the books. Then the judge says, okay, you have purchased the books now. Then other thing, they have unlawfully acquired the books. So they have learned everything, especially in the medical domain. All the books are on ChatGPT and Claude general models. That is why when you say act as a physician, act as, then he goes to those books. But there are specialized medical records software also, which has not implemented in Sri Lanka. That's what I have not but in Microsoft and Google are developing smart doctors to patients as well as clinicians.
Professor Amarasekara, I want to ask a small question from you here. So, what is the status of the plagiarism in case of if we use this for research development and all?
Now in our education domain, there is a big problem in plagiarism. However, we have seen the academics are also plagiarizing and producing their PowerPoint slides by cutting and pasting. Plagiarism is one thing, copying and pasting the same thing. Using AI assistance is another thing. AI themselves are plagiarizing because that is also the Perplexity has got a court case. He was putting the contents on this one. Some people are using plagiarism checkers like what it is, plagiarizing checking is Turnitin. That is what I initially said also, the higher education is people are plagiarizing and professors are trying to catch them. But I think AI assistants themselves are AI. AI assistants themselves are AI. So the plagiarism checkers are also at a question mark. OpenAI, Claude are multinational companies. They have a lot of investment. These plagiarism checking companies are small companies. So they will also try to outsmart us. Therefore, I don't believe on plagiarism checking. If you ask the ChatGPT to rephrase, it will rephrase very nicely. If you go to Claude, you can rephrase. I myself has developed another tool, humanizing tool. Humanizing tool, this matter of prompting. It is very difficult to catch a person with a good prompting. So always rely on human judgment is very important. You have to read the essay to check whether it is plagiarized or not. Recently, what has happened is one of our students in our Viva, our professor Prasanthi Gunawardana, the student has cited Gunawardana, very prestigious journal. She has never published in that journal. So ChatGPT is giving very confidently. Always don't rely on sources. That is why I said Perplexity is okay because it relies on another one is Storm, STORM, Storm by Stanford University. Storm, if you give a comprehensive one, Storm will go through all the links and then the references. Then also you can say ChatGPT, don't give unnecessary one. I want reliable sources from the PubMed or anything, something like that. Then they will do. The thing is, the PubMed is also expensive. Expensive in the sense it is behind the firewall. So ChatGPT cannot illegally get that one. Therefore, it will do something. Storm is a good one for research. Then there are other things like Elicit, Copernicus. There are various research tools as well. Thing is, our researchers are not using these tools. They are not even getting ChatGPT paid version. So digital divide is always widening. USA, China, India, now UAE have come up in an AI in good way. Our people are still using cheap, unpaid version of ChatGPT. So how can you match this one?
Thank you.
Thank you very much for this lecture again.
Thank you very much, Professor Hiran Amarasekara, for that lecture on AI-powered primary care, practical tools for enhanced patient care and clinical efficiency. And to give away the token of appreciation, I invite our moderator, Dr. Hiranthini De Silva. Thank you very much, Professor Hiran, and thank you very much, Dr. Hiranthini De Silva. And moving on to symposium number 5, Primary Care Toolkit for Chronic Illness Management. And I invite the chairpersons once again, Dr. Hiranthini De Silva, who serves as a specialist family physician in Sri Lanka and a specialist GP in Australia, and also Dr. Malkanthi Galhena, who is the... Okay, to chair the session, I have great pleasure in inviting to accompany Dr. Malkanthi Galhena, our immediate past president and the Congress, Scientific Congress chairperson, Dr. Shalini Senaratge. Ladies and gentlemen, the Symposium 5, Primary Care Toolkit for Chronic Illness Management.
It's my privilege to introduce Dr. Uddana Ratnapala, consultant nephrologist at District General Hospital, Chilao, and visiting nephrologist at the National Hospital of Sri Lanka. He also serves as Honorary Secretary of the Specialty Board in Nephrology, PGM Colombo, and he is a member of the National Transplant Advisory Council. He obtained his MD in Family Medicine from the University of Colombo and went on to become an ISN scholar in advanced organ transplantation at Edinburgh. He has led many firsts in renal care in Sri Lanka, including kidney transplant programs in Uva province, the first nephrologist-led CAPD catheter insertion service, and dialysis unit in underserved regions. He also pioneered the hemodialysis bracelet and founded both the CKD Prevention Task Force, Monaragala, and Project Your Kidney LK. Over 30 publications national guidelines and multiple international awards, Dr. Ratnapala is a true leader in nephrology and kidney health advocacy. Today, he will speak on the stage-based approach to CKD management. Please join with us, and I warmly welcoming Dr. Ratnapala. It's over to you.
Yes, thank you very much. It's always nice to be at Family Physicians Gathering, and I have become a frequent resource person in these gatherings. So once again, I was invited by Dr. Udanta Ratgamage, my good friend from the faculty days, and of course the president and of the College of Family Physicians. So let's not delay the scenes. We are already delayed, I think. There's a huge delay, so let me try to catch up with the time. So the topic given to me is the stage-based approach to CKD management. Before going to the lecture proper, I think once again, this is the first slide in any of the lectures I do regarding CKD, the conceptual development of CKD. Once again, my friends, CKD is a place where there is no return. Once it's gone, it's gone. So it's permanent, irreversible, progressive decline of glomerular filtration rate, which lasts for more than 3 months. Now, this is the concept of CKD, but the KDIGO, which is Kidney Disease Improving Global Outcomes, the authority of CKD guidelines in the world, they have given us this particular definition for the purpose of research and for the management. So as primary care physicians, you should know this definition, and let's see what it is. So it says any abnormality in the structure or the function of the kidney which lasts for more than 3 months, it's CKD. So let's look at the function. If your GFR is less than 60 for 3 months, yes, you have got CKD. In addition, if you have even a bit of proteinuria with albuminuria of more than 30 milligrams per gram lasting for more than 3 months, or bit of change in your urine like red cells or red cell cast, a problem in your electrolytes like renal tubular acidosis, any problem in histology like membranous glomerulonephritis, nephropathy, or structure changes like stones or cysts, or even if you had a kidney transplant, you are CKD. Now the problem comes in this audience, there are so many CKDs. You had a cyst, you had a stone, you had a biopsy done, and you underwent a transplant. So almost all in this audience are CKD. The question comes to a GP or a nephrologist, how long my kidney going to last? So I should be able to give an answer. A person who's a bit of red cells in the urine, is he going to lose the kidney fast? A creatinine of 5 with a GFR of 15, is he going to lose the kidney fast? Or albuminuria of 300, who's going to lose the kidney fast? That's why the KDIGO has come up with this beautiful model. So look at this carefully. Everyone has seen it, but probably ignored it. But today's lecture is on this, and entirely on this. So this particular graph is showing horizontally worsening proteinuria. So A1 is denoted as proteinuria less than 30 milligrams, A2 30 to 300, A3 more than 300. So as you know, higher the proteinuria, you are asking for trouble. Your kidney longevity is less. And vertically, you have your worsening GFR. So it's about 90 is stage 1, 90 to 60 is stage 2, 30 to 60 stage 3, 15 to 30 stage 4, and less than 15 is stage 5 and then stage renal disease. So are you happy to be in the green zone, yellow zone, orange zone, or red zone? No one likes to be in red zone, because then they are with me rather than with you. So you'll be managing people in the green zone and yellow and orange, but when it comes to red, it's all my property. Okay, so let's move to the management focus. So this is what we are going to focus at. So we have stage 1 patients coming to you, 2 patients, 3, 4, 5. So your management focus entirely differs. Now the key feature of stage 1, now, do you even consider they as CKD? Is GFR more than 90 with minimal proteinuria? Yes, you have to consider, because they are at risk of progressing to 2, 3, and 4. Because diabetes, if you can remember the pathophysiology, the GFR goes up because of the rising glomerular filtrate. So they have erroneously low creatinine to start with. You think being a diabetic, you have a 0.6 creatinine, you are happy? You are absolutely wrong. You are asking for trouble. You are in trouble and you are progressing towards CKD stage 2, so on and so forth. So if you are in CKD stage 1, you have to control your risk factors of the patient. Proper diabetic control, pressure control, so on and so forth. If you're in stage 2, you have to monitor renal functions more carefully and probably you have to do lifestyle modifications. If you're in stage 3 and 3B, you're asking for complications of CKD, the so-called hardcore complications of CKD are going to arise in CKD stage 3 and 3B. CKD stage 4, once again, probably a nephrologist will plan renal replacement therapy and we'll be managing the complications. Stage 5, it's all about renal replacement therapy. So this was an overview. Let's go to the hardcore of the lecture. So now we are on stage 1 and 2. So there are 10 golden steps. I think I have been telling in probably not in this podium, but in this function, these 10 steps again and again. I don't have anything to add from last year. Same all 10 steps. Let's see whether anything has changed. Number 1 is tight blood pressure control. What is the target? There is a target. No point in mage pressure honda 150 no. They have, KDIGO has clearly given in 2012 the target as 130/80. It should be less than 130/80. And 2024 KDIGO guidelines has given even a lower blood pressure target of 120. So as the College of Nephrologists, we had a huge discussion and a debate among ourselves whether to recommend 120 or 130 for you. You barely achieve 130, can you achieve 120? Patients will faint and die. No. So our decision was argued. In KDIGO 2024, they have asked for office blood pressure measurements. The patient should come, wait for 15 minutes, take 2 or 3 measurements. You have to use the same standardized blood pressure meter. Patient should not be, in a relaxed state. You can't do it in your clinic. So what we used with normal blood pressure to go with 130/80. As far as Sri Lankan guidelines are concerned, which I was a co-author of Sri Lankan diabetic guidelines, it will be coming on your way. On behalf of Ministry request, we have prepared it. It's in the last stages of development and the target would be 130/80. And there are enthusiastic family physicians who would, blood pressure should be kept below 130/80 and you start going down, 120, 110, 100, 98, ooh. You're asking for trouble. So nothing, too much is not good. So the diastolic below 60 increases your cardiovascular mortality and you are going to die of a heart attack. So never a diastolic below 60 and we are comfortable with a systolic around 100. So try to achieve 130 to 100, somewhere around 80 to 60. That would be your target for blood pressure. Then what is the first line antihypertensive you are going to use? No questions in this audience. It's going to be RAS blockade, either AC inhibitor or ARB. AC inhibitor starting from captopril, enalapril, perindopril, ramipril, so on and so forth, or AC inhibitor receptor blockers in the versions of losartan, valsartan, telmisartan, olmesartan, doesn't matter. Whatever the sartan or pill you use, you have to use it. What is the dose? Start with a small dose. Enalapril 2.5, losartan 25, get down the patient in 2 weeks' time. Look for potassium, look for a repeat creatinine, and look for pulmonary edema and blood pressure, and rarely they might develop angioedema. But the reason for this is if the patient is having a single functioning kidney with the unilateral renal artery stenosis or bilateral renal artery stenosis, the creatinine might go up. If it has gone by 30%, you have to stop the ACE inhibitor ARB. If the potassium has gone above 6, you have to stop. But any potassium between 5 to 6, are we going to stop? No, the benefits are such that you are not going to stop, but you are going to advise in low potassium diet. That's what I do. It takes 2 minutes. I see millions of patients. My rahas is all these are in poems. Okay, so this is about potassium. You go with low potassium diet. Then you add a sodium bicarbonate. You can add 600 milligram daily or BD if you are thinking of type 4 renal tubular acidosis associated with diabetes. And the third thing, diuretics is in the guidelines, but we don't like it. Anyway, so that's that. And when to stop? So make sure not just a mild rise in creatinine, don't stop. Mild rise of potassium, don't stop. If there's no flash pulmonary edema, don't stop. Okay, when to start? The evidence is very clear. Type 2 diabetes plus, proteinuria plus, hypertension, clear indication. Type 2 diabetes plus, proteinuria, another clear indication. Type 2 diabetes plus hypertension, you can start. Hypertension alone, still you can start, but not we don't have evidence as such for that. Okay, tight glycemic control, we know it should be tight, but how tight? we go with the HbA1c. And the target, we know, is a range. Nothing in life is black or white, it's a zone, or a range. So 6.5 for a young boy like him, our compeer, he's sleeping. No, that's fine. So if the compeer comes, if I see you, your HbA1c target should be 6.5. Why? He is not frail, he is not having other comorbidities, he is unlikely to go into hypoglycemia. But if I start in on myself, still I am young, but I am not going to take any elderly gentleman in the audience. Okay, suppose if I see a 80-year-old lady who is frail, bedbound, I will keep it around 8. So it's always a target, and as GP, you have to define the target for your patient. Clear? SGL2 inhibitors, we know the importance of SGL2 inhibitor. Again and again, it has been proven beyond doubt. When the EGFR is about 20, despite perfect glycemic control, it gives you cardio protection and vascular pressure. So empagliflozin in a dose of 10 milligram or dapagliflozin in a dose of 10 milligram is the proven. The 25 milligram comes for glycemic control, not for renal and cardiovascular protection. Problems, there may be initial dip of GFR, there may be recurrent genital infections, there may be fungal infections, but try to continue this because it's going to keep your kidney going until you die. Okay, in diabetic kidney disease in proteinuric patients, you have already added ACE inhibitor ARB, you have added the SGLT2 inhibitor, and the third drug in the line is NMRA, non-steroidal mineral receptor antagonist, which is known as finerenone, still not registered in the country. It's available, not registered though, but it's extremely expensive, around 500 to 600 rupees a tablet. If you can afford, if your patient can afford, finerenone will be your third drug in case of proteinuric diabetic CKD management. Low salt diet, I think even in Dr. Hiran Amarsekara's lecture he mentioned, probably he went into my area also. So low salt diet, 5 grams of salt per day, provided that you are not hyponatremic, provided that you are not polyuric. So low salt diet is a must, and it helps your heart, it helps your kidney. Weight reduction, what is the BMI? The current recommendation is 20 to 25, like mine. Doing too many lectures and doing too many patients is keeping my BMI towards 30 rather than 25. So, but the target is 20 to 25, so try to achieve this target, and exercise is a must. So give this package, this 10 rule package is a must if you are seeing a CKD patient and having diabetes, So the exercise time is 30 minutes a day, 5 times a week. Okay, that's also done. Then lipid management, the next step, lipid management, statins for all, is it correct? Almost yes, because all diabetic CKDs should be on a statin. What's the target? There is no LDL target, should be on a statin. It's as simple as that. This is for cardiovascular prevention. Then for CKDs without diabetes, over 50, all should be on a statin. So you should be very clear, all diabetic CKDs should be on a statin. You don't have to even look at the lipid profile. All CKDs not having diabetes over 50 should be on a statin. This is because they are high cardiovascular risk, because CKD carries inherent risk of cardiovascular event. The MI is coming, it's on the way, stroke is on the way, you should prevent it. Don't wait until your lipid profile short is up. And if the patient has got secondary, needs secondary prevention, had a MI or unstable angina, your LDL level comes down to 70, and if it is a severe case, it comes to 55. So all the GPs are happy with LDL of 100, 120. Absolutely wrong. It's 70 or below. In severe, like cardiologists keep it at 55 or below. Otherwise, you are giving a statin, it's not serving the purpose. Avoid smoking, active or passive, no questions asked. And nephrotoxics is always a slide in my lecture. Non-steroids, all non-steroids are nephrotoxic, and you can see even the ACE, ARBs, and SGLT2 inhibitors they are in the nephrotoxic list. That's wrong, they are not nephrotoxic, but when the patient is sick, you should stop them temporarily. So make sure that you stop ACE inhibitor, ARB, and SGL2 inhibitors temporarily because they reduce the interglomerular pressure. So all inward patients undergoing AKI, you having AKI, or at risk of AKI should not be on ACE inhibitor or empagliflozin for 24 to 48 hours until the things are settled. Okay, moving to stage 3A and 3B. This is the new version, so moderate renal function, and you expect anemia to develop, you expect mineral bone disease, all these electrolyte problems to develop, and referral criteria to nephrology comes somewhere here. Okay, once again we rehearse the 10 golden rules plus low protein diet. Is there evidence? 2012 KDIGO guidelines says 0.8 gram per kilogram per day, kind of, so that's around 100 gram, 2 pieces of fish per day. But 2022 nutrition guidelines, KDIGO guidelines tells us go even lower to 0.6, and it says to go to 0.35, a very low protein diet, and supplement it with alpha keto amino acids. Now these alpha keto amino acids have basically made in such a way that all the bad parts of the protein is removed, so you can give it to the patient, even CKD patients. Problem is they are extremely expensive. One tablet costs around 200 rupees. You have to give 6 tablets a day, so 1,200 to 1,400 a day if you go for low protein diet. So as per today, as we are living in Sri Lanka, which is a developing country forever, we might not be able to use this drug. What we will go is for a moderately low protein diet. So the current recommendation we practice as nephrologists is 0.8 gram per kilogram per day. So slight reduction of protein is what we practice. But before embarking on a low protein diet, make sure you look at the patient. For example, yes, probably you, if I start a low protein diet on a malnutrition, malnourished not. Okay, malnourished family, no, malnourished patient, it will look very bad. So make sure that you look at the patient, and if patient is already in a protein malnutrition, don't go for a low protein diet. Okay. So anemia management, it's very easy. I know the practice of the family physician and GPs start iron weak or folic acid and add erythropoietin. No, that should be the management. Let's see, let's take it as a question and see who gives the correct answer. All patients with CKD stage 3 and having anemia should be treated with iron, vitamin B and folic acid. If you do audit, 99.9% they are on iron, folic acid and Vigo. Is it correct? The answer is no, because anemia can be due to multiple reasons even at this level. Once again, you have to go back to your basics and see whether it's pancytopenia, bicytopenia, anemia alone, microcytic, normochromic, normocytic. Then depending on your this thing, whether it's so on and so forth. So at least you have to do a couple of investigations before starting on iron. We see a lot of iron being used, but iron is not good due to these reasons. Iron overload in the prolonged use of iron, oxidative stress in your patient, a lot of GI side effects as well as infection risk if you use IV iron, which is what we use, and most of the GPs won't use it. And finally, the pill burden and the cost. So make sure you give supplements after proper evaluation of anemia like you do in any other patient. Okay, very easy. All patients with CKD stage 3 and below having anemia should be treated with erythropoietin. True or false? All should be given erythropoietin. Absolutely wrong. I have seen this being used. It's a real malpractice in the country. Do you know the vial of erythropoietin? Because we are doing the tenders these days, and one 4,000 vial is 4,400 rupees. And if you ask patient to take it from outside, just imagine. So a couple of low-cost versions are coming. We don't know the activity of it. So erythropoietin is expensive, first problem, and it causes hypertension. And you can't control your patient's hypertension and you give erythropoietin. Doesn't make sense. So it's difficult to control hypertension when the patient is on hypertension and if the patient eating a lot of salt. And thromboembolic events are high, increased cardiovascular disease, and tumor progression in some tumors, so on and so forth, and extremely expensive. So make sure that you evaluate for iron deficiency, vitamin deficiency, and other causes of anemia, and you know it is due to renal. When the hemoglobin is less than 10, with ferritin above 200, you start erythropoietin to keep a target of 10 to 12. Then mineral bone disease, no question, all should be on 1-alpha and calcium carbonate. That's what I have seen. Once you diagnose CKD, especially stage 3 or B, you straight away add 1-alpha and calcium carbonate. Are you going to kill the patient? No, keep the patient alive. No questions asked, you are going to kill the patient. How? Let's see. Now, it's not as simple as, mineral bone disease can come in different ways. It can come as secondary hyperpara, tertiary hyperpara, osteomalacia, osteoporosis, and adynamic. Suppose your patient has got secondary hyperpara and your phosphate is already high, and you start 1-alpha CCF, or any vitamin D derivative for that matter, and it increases phosphate absorption from the gut. Your phosphate is already high, and you make the phosphate go up further. You know hypophosphatemia is a killer, and it increases the cardiovascular risk. So you kill this patient not by kidney disease, by a myocardial infarction. So without doing a proper paneling of calcium, phosphate, alphos, preferably intact PTH and vitamin D levels, don't start on 1-alpha and calcium carbonate as a holistic approach. You should put something for a CKD patient, just don't put 1-alpha and calcium carbonate. And if you're going to put calcium carbonate for the third patient or second patient with high phosphate, should you give calcium carbonate 1 BD at 10 a.m., 10 p.m. or with meals? Patient's calcium is, say, if it is low, if it to be given as a supplement, you should give well away from meals. And if you give it as a phosphate binder, you should give with the meals that whatever the phosphate you eat will make calcium phosphate in your tummy, and it will get precipitated and go out. So whether you give it as a calcium supplement or a phosphate binder is very, very important. So timing and the drug is very important. So don't holistically write about 1-alpha and calcium carbonate for all. Study the case. There's not enough time to teach you mineral bodies, so maybe next year you'll see. Anyways, so management of hyperuricemia, allopurinol for all. CKD, allopurinol. Agree? Absolute myth and absolute malpractice in the current day Sri Lankan practice. So allopurinol, once again, these KDIGO guidelines I have quoted, we suggest not using to lower serum uric acid people with CKD and asymptomatic hyperuricemia to delay CKD progress. There is no evidence. If the patient has got documented gout or uric acid stones or uric acid levels more than 9, they recommend not. There is no strong evidence as such, but this is where you start your allopurinol. And allopurinol, mind you, carries high risk of hypersensitive reactions, Steven Johnson, and there are enough and more cases we have seen people dying because of allopurinol. So whenever you start this kind of drug, make sure that it has a proper indication. Okay, moving to metabolic acidosis. All CKD should be on sodium bicarbonate. You have seen, no, even the nephrologist use sodium bicarbonate straight away. Sodium 600 daily, 600 BD. Is it correct? Absolutely wrong. Why? Sodium bicarbonate, my dear friend, is carrying bicarb molecule as well as sodium. Now sodium is LUNO. Now you ask patient to be on a low salt diet to prevent hypertension, volume overload and all, and you are giving sodium bicarbonate. How rational is it? So that's also wrong, because sodium bicarbonate can give rise to fluid overload, hypertension, hypokalemia, and GI discomfort if you have given it to any patient. So there is no real indication except in patients with documented serum bicarbonate level less than 18. So ideally you have to get at least a venous bicarbonate or arterial bicarbonate and document that patient has got metabolic acidosis on board, and then only sodium bicarb should come into the play. Not good. The practice is being transformed. Still we are doing age-old things, but our ancestors and the ancestors and the ancestors, what they did, we are continuing. 1-alpha calciferol, I think I learned from, probably my ancestors, and sodium bicarb. Okay, finally nephrology referral, always controversial when to do it. In the KDIGO guidelines, it's EGFR less than 3 and USCR more than 300, but we don't agree with that due to multiple reasons. So our Sri Lankan guidelines will come up, because when the creatinine to go up by 0.1 above the normal range, the GFR drops by 50%. This is physiology. And with a GFR of 30, 70% of kidney function is already gone. And let's look at number 5. How can we add renoprotective drugs? SGLT2 inhibitors should be added with a GFR about 20. You are referring at 30. There is no time to work. Then to add the NMRA antagonists, it's EGFR of 25. You are referring as 30. So we are not comfortable when a person comes with this one. And the major problem is in developing countries, do we have an allotted GP network ensuring linear follow-up? The patient changes from one doctor to another, and there are no clear guidelines for follow-up. So this is high risk. So let's not talk about referrals and go into stage 4, begin the discussions of renal replacement therapy, vaccination, and these are the vaccinations we recommend at the stage 4. Probably this patient is with a nephrologist now. And finally, when the patient comes to stage 5 CKD, where I started playing my game, hemodialysis, I don't have, CAPD, I don't have, renal supportive care, Anyway, that happens without proper palliative follow-up, and kidney transplantation I don't have. Don't send. So by sending patients to us at stage 5 CKD, we don't have anything to offer. If you have been to any of the Ministry of Health meetings, the nephrologists and ourselves, we don't have the number of hemodialysis machines we need. We don't have money to buy CAPD fluid. We don't have money to buy anti-rejection drugs. So the government transplant program is going down. And for renal supportive care, we don't have any palliative structure. So it's only death, and it's going to be agonizing death. It's not going to be a nice death. And renal supportive care is offered for people over 75 years with these 4 criteria. I look at you, the first question I ask is whether you will die whether I will see you in 6 months' time. If it is a no, then I look at the frailty score, you can't just walk, you are so frail. Comorbidity score, number of diseases you have got, malnutrition score. If all yes, 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 I will offer conservative care. Here, if you can't undergo hemodialysis, if you can't undergo transplant, if you can't come for CAPD, even at age of 45, it's renal supportive care. So that's how pathetic situation is. So I love to come and talk to you because you are the people who can prevent CKD from progression to CKD stage 5 and dialysis. If you don't work hard enough, if you don't learn these very, very important core criteria of management, the patients are going to die in agony. So please don't make any of the mistakes I mentioned today, and make sure you follow the 10 golden rules and the other important myths that I have busted. Thank you very much. Thank you very much again, Udanta and Family Physicians, for giving the opportunity. Thank you.
I invite you to come and be seated with us, and after the next lecturers, the symposium will be ended after that, so the questions will be left to the end of this symposium. On the request of Dr. Udana, so since he need to go early, so we ask from the audience if you have 1 or 2 questions, because we are behind the scheduled time. So you can ask from him because he's in a rush to leave. I have one question, Dr. Udana. Since the researchers have proved that irbesartan, the use of irbesartan on the CKD patients, slows down the declining of the eGFR. So I know that you are working at the state sector as well as the private sector. What is your experience regarding the use of ARBs over this irbesartan? Any difference in that you are experiencing, even though researchers are telling?
So absolutely correct. So irbesartan was used in many of the trials. That's why irbesartan is kind of superior in the practice. But in my practice, in the government sector as well as in the private sector, I don't see much of a difference by using this. So the important thing is patient should be on ACE inhibitor or ARB, and it should be the maximum tolerable dose. That's a mistake we do. We start irbesartan 75 and never go up to irbesartan 300 daily. Losartan the same, you start at 25 and never go up to 50 BD. Now Elrapil even to 40 milligrams. So maximum tolerable dose of patients, and you titrate with the proteinuria. What we titrate is with either the blood pressure over the creatinine, but the important thing is until the proteinuria goes to a minimum and until the patient becomes symptomatic. That's why it's called maximum tolerable dose. So in a country like ours, we don't specify on any of the ACE inhibitors or ARBs, but please make sure that you go up to the maximum tolerable dose and the minimal proteinuria that you can achieve by doing so.
Thank you very much. And it's, thank you very much for your very much the updated, informative, the speech that for sure the primary care physicians will be updated and put into practice. So I highly appreciate it.
Sir, I have one question if possible.
Yes.
What about the place of diltiazem and cilindipine as antiplatelet drugs? And number 2 is when to come off the ACE inhibitors, ARBs at what stage of eGFR?
Okay, good question. So diltiazem and cilindipine, yes, we do use. So you will, if I say no, then you will, quote me by looking at one of my prescriptions, because cilindipine is not trial proven for longevity of the kidney or cardiovascular outcomes, but it has proven it reduces proteinuria. So thinking, in a long run, we use diltiazem and cilnidipine because of its inherent property of reducing proteinuria. So nifedipine and amlodipine, on the other hand, increases proteinuria. But cardiovascular, especially cardiologists, they like amlodipine so much. As nephrologists, we like diltiazem and cilnidipine so much because whatever the proteinuria reduces, we theoretically believe that patients get benefit out of it, but it's not. There is not much evidence as such. The next question: when to stop ACE inhibitor ARB? Yes, you should continue even at CKD stage 5 and even on dialysis. Now there is no stopping of ACE inhibitor ARB once you start it. You continue it, and because even on dialysis patients, the hypertension drive is due to 3 reasons: fluid overload, sympathetic activation, and RAS activation. So because of that, patient should be on ACE inhibitor ARB. But if the hyperkalemia is troubling you, say it's almost always above 6.5, and doing those things, putting on a low potassium diet, adding on sodium bicarb, adding on a bit of diuretics for caliuric effect, you are not getting your potassium control, then that's one place you will stop. Other place would be this rise of serum creatinine due to renal artery stenosis, which is not that common, so it's not this one. And in AKIs, for example, patient is admitted with a diarrhea, vomiting, or with a snake bite for some other reason, patient is having a diarrhea, especially inward patients, we like to stop ACE inhibitor and ARB temporarily, but make sure as GPs you restart it after discussing with the nephrologist that you have to restart it once the AKI settles. Thank you.
Well, ladies and gentlemen, that concludes the first session of the Symposium 5, and that was Dr. Udana Ratnapala, Consultant Nephrology of District General Hospital, Chilava, who conducted the session on stage-based approach to CKD management. And with great pleasure, I invite the chairpersons to give away the token of appreciation to Dr. Udana Ratnapala. Thank you very much, and once again I request the chairpersons to take over the stage for the next session of the Symposium number 5, Primary Care Toolkit for Chronic Illness Management.
The next session on Primary Care Toolkit for Chronic Illness Management would be an expert Q&A session by Dr. Udita Buligahapitiya, Consultant Endocrinologist, National Hospital of Sri Lanka, and the audience please be informed that you have the opportunity to ask questions. It's my great privilege to introduce our resource person today, Dr. Udita Buligahapitiya, MBBS, MD, MRCP, FRCP, FCCP, FACE, FSLCE. Consultant Endocrinologist, National Hospital of Sri Lanka. Dr. Udita Buligahapitiya, Consultant Endocrinologist at the National Hospital of Sri Lanka and Founder President of the Sri Lanka College of Endocrinologists. He also served as the first editor of the Sri Lanka Journal of Diabetes, Endocrinology and Metabolism. Dr. Buligahapitiya graduated MBBS from the University of Peradeniya, obtained his MD from the University of Colombo, and trained in endocrinology at the University of Sheffield and Royal Hallamshire Hospital NHS Trust in the UK. He holds multiple fellowships and has pioneered diabetes and obesity care in Sri Lanka, establishing the country's first and largest obesity services unit and research center. With over 100 publications and international recognition, his contributions have been widely acclaimed, and in 2019, he was awarded the National Honor of Deshamanya. Today, Dr. Buligahapitiya joins us for an interactive session, Diabetes in Special Situations, an expert Q&A session. Please join me in warmly welcoming Dr. Udita Buligahapitiya.
Thank you very much, ladies and gentlemen. It's a pleasure to be here today. And actually, I'm ready to, if you ask questions quickly, I can answer the questions, more and more questions. anything about diabetes is okay, I suppose, yeah. Or even endocrine is all right.
So, sir, I have a question first of all. Now, it's becoming a trend that even diabetics as well as non-diabetics practice these intermittent fasting techniques with ketogenic diets. So, what is your recommendations regarding using these long intermittent fasting methods for diabetes in long-term management?
Yeah, actually, diets and diabetes, I think if you read yesterday's EASD journal yesterday, actually published yesterday, and there are loads about the diets, and ultimately the best diet for healthy living as well as for diabetes is what you and I eat. Like portion size is the most important. At least 50% should be carbohydrate, so half the portion should be carbohydrate, then the quarter should be protein, quarter should be the vegetables. Now all other diets have been actually tested in that and shows mortality. High protein diet shows increased mortality. High protein diet shows that increased mortality not only due to diabetes but also due to the colonic cancers. So I think intermittent fasting is a very short, have some evidence, but for a shorter period of time. But when you have diabetes, it's a lifelong disease, and if you want to live healthy, it's a lifelong thing. So I think going for a shorter period, try and reduce weight is good, but ketogenesis for too long is not going to work. Even the exercise is the same. I think you have seen this data in EGM about 2 weeks ago, and if you do more exercise, again, you are having higher mortality. So it's again a same curve. So I think it's again about a 1 hour exercises and the portion size and try and maintain the weight is the best way forward.
Audience, you have the opportunity to ask questions from Dr. Bulugapitiya.
Sir, one question here. Could you please explain regarding diabetes remission and what are the effective measures we could tell our patients to achieve that, and what are the best candidates? I mean, who are the best candidates to achieve that, please?
Yeah, diabetes remission is actually the latest version of it. Actually, in a Western country and even US, a huge sum of money is actually invested in diabetes remission. And it is, if you look at the early studies, actually it is very low calorie diet for first 3 months. Then what you do is around 10% weight reduction. When you have a 10% weight reduction, usually what happens is that you go into the diabetes remission. The weight is the most important thing. If you can reduce 10%, yes, you are going to remission of diabetes. And what has happened is that actually the best candidates are the shorter duration of diabetes, newly diagnosed diabetes. When the patients are having pre-diabetes, a good thing to make sure that they are not going into the diabetes. When you are having long duration of diabetes, it's pretty less likely that you are going to go into remission. Now, newer studies are also there. Now, what happens is that when you do diabetes remission for 3 to 6 months, it is very difficult to control on a very low calorie diet. It's not necessary as well. After that, you are going to basically a normal diet, but it is a portion size again with exercise and diet. Problem is that about 30 to 40% will recur the disease in about a year's time, and in about 2 years' time, about 80% will recur the disease. Now for that, if you read again, I think last week publication, what they have done is that they are going to the very low calorie diet and then reverse the disease, and then they have gone for a GLP-1 analog with a weekly basis to try and have a long-term remission of diabetes. But exactly you can't use the remission because you are using a tablet injection or whatever they are. But I think remission is a good thing. If you have a newly diagnosed diabetes, obesity, associated with diabetes, family history, then I think the best way is to go into the remission. Try and get the lifestyle modification first 3 to 6 months, and then you can either go without medication. Continuation of the lifestyle is important, and if somebody can afford something like a GLP-1 weekly injection would be a better option.
Dear sir, in current practice, in management of diabetics, HbA1c level is considered as should be as 6.5 or less than 6.5. But sir, there are some patients in elderly, like especially they had multiple comorbidities. What should be the lowest level with diabetes? Because there's a risk of hypoglycemia and other comorbidities.
Yeah, I think management of diabetes in elderly is an extremely an important topic because if somebody can be around 70, 75 years of age, still very physically fit, not having any other comorbidities, and doing day-to-day things independently. So that's almost like a person who is having young age, in a young age. So in that case, you can have a HbA1c 7, no less than 7 for that person. But if somebody has, elderly age with multiple comorbidities, having dementia, activity of daily living is poor, then you need to rethink about what is the best HbA1c cutoff for this elderly. Probably 8.5 would be okay. At that time, actually, what we are trying to prevent is that hyperglycemic complications. Hyperglycemia should not be asymptomatic. Hyperglycemia should not be causing infections. Other than that, at that age, 8.5 would be okay. So the best medications at that point is that metformin low dose is okay, because if you go into higher doses of metformin, it will affect the appetite, because appetite is so important in elderly, because you have to have a high protein diet to keep the proximal muscles intact, unless they can fall. So I think important to keep the healthy muscles. Therefore, metformin low doses is good. But if you're going for sulfonylurea, you have to be very careful. Go for short-acting sulfonylureas because that can cause hypoglycemia. If you get a hypoglycemia, fall, hip fracture, your management is over. So I think you have to be extremely careful not to cause a single hypoglycemia in elderly patients, because their brain is depending on blood supply and the oxygen supply. So if you cause hypoglycemia, that's the end story. SGLT2 inhibitors are quite good, but make sure that renal infections can be a problem, because you have to tell the patient to wash and wipe. Wipe is the most important point here, not the wash. Wash and wipe is the most important point when they urinate. And GLP-1 analogs are quite okay, but weight loss is the issue here. But you have to think about if the patient is a obese patient in elderly, quite a good drug. Pioglitazone, water retention is a problem, therefore may not be the best. So you can select any of those. Insulin is, you have to be very careful, because at elderly you can cause hypoglycemia. So if you really want to, a basal insulin would be the best with the oral medication. That's quite good. If you can achieve a HbA1c of 8.5, very good. I think even at elderly, the other measures are very important, because you are looking at a cardiovascular outcome benefit. So not only the glycemic target. If you look at the glycemic target versus the pressure target, even in diabetes, pressure target is more important in reducing the cardiovascular risk. So get the blood pressure control less than closer to 130/80, and also the cholesterol control is important. After 80 years of age, statins have no evidence, but still if the patient is on statins, you can continue, but not to cause any problem. So I think very important thing is the multiple risk factor approach even in elderly, not only concentrating on HbA1c, because HbA1c is only one part of it, and also the proximal muscle improvement, vision improvement and things are very, very important. And also they should have reasonably a good diet, because unless they will lose their muscles. So I think elderly medicine is very, very important, and I think it is, you can select we have lots of medications. I think previously also asked about a question about DLTSM actually, with very cheap medication, very good medication, because why I'm saying that, the ACE inhibitor, ARB blockers are good, right? But next option is a calcium channel blocker. With any of the guidelines, calcium channel blocker. So go for the cheapest calcium channel blockers. First thing is to get the target pressure control to reduce the cardiovascular and the renal outcomes. And the second option is that what you select for the blood pressure reduction. Then ACE inhibitor and ARB blockers coming up. But when the proteinuria is present and the pressures are normal, ARB and ACE inhibitors and ARB blockers, action is minimal. There is no outcome benefit at that point. There are SGLT2 inhibitors and the finerenone will come in, because that's how actually they work, the action on the kidneys. So if the pressures are normal, proteinuria, ACE inhibitors, ARB blockers, action is very much less.
I'm an acting consultant family physician. So I would like to ask, actually in primary care, a lot of these family physicians, they're looking after diabetic patients. So when the type 2 diabetic patients, so we start from metformin, then Sita or we are going step by step at the maximum doses, tolerable doses of oral hypoglycemic agents, but still the blood sugar is not controlled. Just to introduce insulin, what is the basis, what sort of actually calculations we should make?
Question is that how do you start insulin when the patient is on maximum tolerable doses of oral tablets? I would say that metformin is quite a good tablet, probably cardiovascular neutral. Majority of the studies have shown there is no cardiovascular benefit, but that's all right. There is no benefit, but there is no bad outcome. Then the glycoside are cardiovascular neutral. That's fine. It's good. Sitagliptin, quite costly, cardiovascular neutral. Therefore, I think it should select after the SGLT2 inhibitor in our setting, because SGLT2 inhibitors are quite cheap, cardiovascular and renal benefit, so it should come up. And the fourth should be the sitagliptin, I suppose. When you're on the maximum tolerable doses, and if you're unable to get the HbA1c control, then you have to decide what sort of medication that you're good for. If your HbA1c is less than 10.5, with the oral maximum medication, then the next option should be basal insulin. Next option is the basal insulin. But if your HbA1c is more than 10.5 with a maximum tolerable doses of oral medication, then basal insulin has no place because it will not control the blood sugar. So with the HbA1c, you can decide what form of medications that you are going to add next. If the HbA1c is less than 10.5, you start a basal insulin, one shot at the bedtime is a good option because patients are very convenient to take it at bedtime. So oral maximum medications plus bedtime insulin. So when you go like that, you are actually titrating your fasting blood sugar to between 90 and 130. When the fasting blood sugar is between 90 to 130 and HbA1c is on target, then you are done, you're okay. But when you are unable to get the fasting blood sugar, when you get the fasting blood sugar 90 to 130 and your HbA1c goes up more than 7, that means you are failing the basal insulin. So you need one other insulin, either with the biggest meal you take, or then you can go to the pre-mixed insulin twice a day. So I hope that you got the point. So oral to basal, basal to basal 1+, or basal, you can remove the basal and go for 2 pre-mixed insulins. So that all depend on your HbA1c. I think according to the HbA1c, you can decide how you should go on these medications forward. But having said that, now we know that 2025 guidelines of ADA EASD last month, if you look at it, actually if you have a high cardiovascular risk, established cardiovascular disease, you are starting with the SGLT2 inhibitor. That's the international data I'm saying. If you're having a established kidney disease, you are starting with the SGLT2 inhibitor. Or you can go for GLP-1. So next option is the metformin. But in our setting, when we have a resource poor setting, I think still we can start with metformin. Then next could be probably the cheapest medication is glycoside. Then think about SGLT2 inhibitor. Why I'm saying that is that we are 100% sure that SGLT2 inhibitors are renal and the cardioprotective. But if you look at our data, we have a 2019, we actually did a study on best center in national hospital centers, the tertiary care center. What is the percentage of patients who are achieving HbA1c less than 7? It is 20%. Extremely poor, right? So we can't, if we have enough available medications, but still we are achieving only 20%. HbA1c 8, about 30%. So when you compare with the international data, with the UK data, it's about 70%. So I think we are extremely poor with HbA1c achievement with available medications. I think, therefore, family physicians and GPs here should be able to understand that we can use the available medications in an evidence-based manner better. Then think about SGLT2 inhibitor, because probably next year we'll get to the Ministry of Health, SGLT2 inhibitors, because quite cheap, but not to misuse these medications.
So in patients with diabetes, when we are starting the statin, how the medications should be adjusted and how often we need to monitor the blood glucose?
Yeah, even if you look at the best guidelines in the world, ADA, EASD, at the starting point you do a lipid profile. Even if you can't do a lipid profile, you can still start the statins. If you start the statins, you can actually repeat lipid profile in about 6 months' time to see whether you achieve the LDL target. And after that, you can do yearly or once in 2 years. So we are actually misusing our lipid profile a lot. So I think if I tell you how to start, up to about 40 years, if you have established cardiovascular disease, you start a statin, there is no doubt about it. And if there is high risk factors, then still you can start less than 40 years. 40 to 75 years, established cardiovascular disease, high intensity statins. If you have a risk factors only, then you have a moderate intensity statins. After 75 years, of course, the patient is on established cardiovascular disease, high intensity. If you have a low risk, you can continue whatever the statins you want. So basically, you are in the either moderate or high intensity statins. High intensity, especially with established cardiovascular disease, so very high cardiovascular risk. How do you diagnose very high cardiovascular risk in diabetes is the question. So if you are having established cardiovascular disease, yes, there is a very high next cardiovascular event. Other things are like if you're having a CKD less than 45, EGFR less than 45, high risk. 45 to 60 EGFR with macroalbuminuria, again high risk. Then if you have 3 microvascular complications in one patient, retinopathy, neuropathy or nephropathy, like 3 microvascular complications, that patients become very high cardiovascular risk. All these patients need high intensity statin, getting the LDL cholesterol to 70. If you have very high risk, 55 is the target, high risk 70 is the target, other patients 100 is the target. So I think basically it's very simple. Statins are very cheap. Almost all the studies have shown that statins have shown reduced cardiovascular risk. Therefore, no doubt you should start statins. Statins are liver friendly, definitely liver friendly. You need not to worry about it. And muscle aches and pains are very much less with statins. If there is a problem, then you have to think about other causes like hypothyroidism, vitamin D deficiency. You need to look for if the patient comes and tells you about muscle pains. And earlier there was a problem of dementia. There is nothing in the new studies have almost exclude dementia with statins. Therefore, I think statins are extremely safe. Use it properly. I think you can reduce the cardiovascular risk.
What are the key aspects of postpartum care for women with type 2 diabetes?
I think before going into the postpartum care, I think the preconception care is the most important thing as a family physicians, I feel. Whenever you see a lady who is in the fertile age group, preconception care is the way forward. You have to get them to have a better diet, get them to lose weight, try and get the BMI into the correct BMI, look for diabetes if there is a strong family history, look for thyroid disease if there is a strong family history. Those are extremely important because when the conception happens, organogenesis is done. Because when we know that the patient comes to us in 2 months or 3 months with delayed periods, organogenesis is completed. So the damage is done. Even the hypothyroidism damage is done. Diabetes damage is done. So I think it is important as the family physicians to give the preconception care. We have a very good data for the preconception care. About 40 to 60% of our newly married couples are getting this preconception care in our own data. Even if you compare with the American data, same. So I think first thing is get the family, get them to understand preconception care is important. If they have diabetes, the HbA1c should be less than 6.5. and the pressure should be less than 130/80. ACE inhibitor should be removed. Statins should be removed prior to the conception. When conception happens, organogenesis is over. After that, you can't talk about that. The congenital abnormalities have set in. After that, we are looking at the larger babies and other stuff. So I think it is important that preconception care. After the conception, actually after the delivery, what happens is that if you're having a diabetes, we know that if you have a GDM, very high risk of getting type 2 diabetes within next 2 to 5 years. It's about 50% in 5 years, 2 to 3 years about 30 to 40%. Therefore, you have to give them correct advices because most of these mothers, they start breastfeeding, they again start eating for 2 people because they are breastfeeding. No, should stop it immediately because breastfeeding, everything is deposited in mother. You need to just have a normal diet. Nothing else is needed. Therefore, mother should lose the weight within first 6 months to the pre-pregnant weight, unless they will never lose weight. Therefore, it is important that you give the correct advices, lose weight, correct diet, exercise, get the preconception weight, and monitor blood sugars every yearly to avoid getting diabetes in future. I think one word about type 1 diabetes, I just want to tell this. If you see a type 1 diabetes anywhere in any of your practice, please refer to the closest endocrinologist center. Because if you look at our data, we have recently seen our data, if you diagnose type 1 diabetes less than 10 years of age, their life expectancy is 39 years. In my clinic at the National Hospital, I don't have any patients more than 40 years of age type 1 diabetes. But if you look at the UK data, their life expectancy is like 69 years, 70 years. So we are, in a huge problem here. We give all glucometers, strips and everything, injections, pens, all free for the type 1 patients. Therefore, please refer them to the closest place, because it's very difficult, because carb counting is necessary. We go by carb counting, not by this basal bolus regime.
Yeah. Thank you, Dr. Bulugahapitiya, for that very interactive and session answering all the burning questions of our fellow family physicians. And thank you for being here with us.
Yeah, anyways, sure.
This is regarding whenever a patient comes with, we'll say for the initial diagnosis with catabolic symptoms and hyperglycemia. So still, we are going to start medication even without waiting the investigation set, which is coming available in 2 weeks' time like the normal practice. So I would like to ask whether still the metformin can be prescribed as a safe medication.
I think newly diagnosed diabetes is the question. I think that is a very good question to answer. If you see a newly diagnosed diabetes, I have seen this many times. Now, patient comes with a fasting blood sugar of 300, but only one blood sugar is available. Patient doesn't have any symptoms. Doctor see this patient and say that you have to have another blood sugar, so go home and do another fasting blood sugar and come. Because only one blood sugar is available, patient is asymptomatic. According to the guideline, he is correct. Now, another patient comes with a fasting blood sugar of 135, symptoms. Symptoms are diabetes. Now, symptoms of diabetes is there, one blood sugar is enough, you diagnose and treat. See what has happened. Now, if you ask your mother, if somebody comes with a fasting blood sugar of 300 and a fasting blood sugar of 140, whom they will treat? Your mother will say that 300, you start immediate treatment, right? But as doctors, we don't do that. We are waiting for the second blood when the fasting blood sugar is 300. So I think this has to be stopped. When your blood sugars are very high, 50% of the patients are asymptomatic. Diabetes are asymptomatic, therefore they won't get any symptoms. So you have to do just a finger prick capillary blood sugar. It can be about 400, 500. Immediately start medications. Now, HbA1c is important. If you have HbA1c of 12.5, we know that most of the medication, like metformin will cause reduction of 1.5 of HbA1c with a maximum tolerable doses. Glycoside is 1 to 1.5 again. Sitagliptin is like 0.5 to 0.6. And SGLT2 inhibitor is about 0.5 to 0.6. So if you have a newly diagnosed diabetes come to you with a HbA1c of 12.5, you need minimum of 3 medications to start with. So metformin, glycoside, sitagliptin, or metformin, glycoside, SGLT2 inhibitor, maximum tolerable doses. If you have a patient who comes with a fasting blood sugar of 300, how many tablets? If you don't have the HbA1c, how many tablets you need? Metformin will reduce fasting blood sugar maximally 70 milligrams per deciliter. Glycoside will again 70 milligrams per deciliter roughly. Sitagliptin around 50 milligrams per deciliter. SGLT2 inhibitor will again reduce about 50 to 70 milligrams per deciliter. So you need again 3 medications. So start with. So you start initially with 3 medications. If you see a fasting blood sugar 300 plus. So when you start, when to see is the other question. Now most of these medications like metformin, glycoside, sitagliptin, pioglitazone will take about 2 to 3 months to act. Pioglitazone will take 3 months, about 10 weeks. Other 3 medications, 80% of the benefit will give in about 8 weeks. So 2 months time. So if you start 3 medications without SGLT2 inhibitor, you are going to see this patient in 2 months time. So because at 2 months time, the maximum benefit is given. But if you start SGLT2 inhibitor, yes, you start today, within hours action is there. So you have to think about, if you add a SGLT2 inhibitor, when to see the patient again about 2 to 3 months, because other medications take 2 to 3 months to act. So frequent visits to hospital should be stopped. When you see the first time, patient will be seen in the 2 months time next time, done. I think majority of the patient needs no hospital admissions if you have fasting blood sugar or HbA1c high. If there is no infection or septicemia or a pneumonia or something like that, all the patients should be managed as outpatient, because if you admit these patients, they will get something like TB. If you just go around TB, they get the TB, because TB in diabetes is a major problem worldwide at the moment. Therefore, don't admit, treat as the outpatient, and infrequent visits, more than enough. And you need not to get all the investigation. If you have fasting or HbA1c, you start. And then you do the lipid profiles and other things variably. What we have seen a problem is that after 2 months, you see the patient. Patient comes with a fasting blood sugar of 110 in 2 months' time. Then you continue the same and see the patient in 3 months. Patient comes with a severe hypoglycemic episode. Why? When the blood sugars are coming down, what happens is glycemic toxicity goes off. Therefore, beta cells start functioning better. When you treat, lipid toxicity goes down, therefore beta cells start working better. If you don't cause glycemic variability also damages the beta cells. Nicely coming blood sugars down, beta cells will start working better. So after using in 2 months' time, you have to reduce the medications to a bigger way, unless patient is going to get a hypoglycemia. Because I think if you can, as young doctors can remember these things, I think you can manage these patients very effectively.
Thank you very much, sir, again, for sharing your expertise with us. And please do accept the token of appreciation on behalf of the college.
That concludes the special expert question and answer session, Diabetes in Special Situations, conducted by Dr. Udita Bulgahapitiya, and the chairpersons will be handing over the token of appreciation and the certificate to Dr. Udita Bulgahapitiya. Thank you very much, sir. And requesting the chairperson to continue with the symposium number 5, which is next is the ECG challenge. Are you ready? It's another quiz that, like in the morning, we'll be going, we have to go through the app. Please take the QR code down, scan it, and get ready for the next quiz, the ECG quiz. And I invite Dr. Malkanti Galhena to read the citation of our next facilitator, that is Dr. Kirti B. Divulweber, consultant cardiac electrophysiologist.
Ladies and gentlemen, it's my pleasure to welcome you to this interactive session. Our distinguished speaker is Dr. Kirti B. Divulweber, consultant cardiac electrophysiologist at National Hospital of Kandy. Graduate of University of Colombo, he trained in cardiac electrophysiology at the National Hospital of Sri Lanka, and later he completed a prestigious cardiac rhythm management fellowship at the Royal Papworth Hospital, Cambridge, UK. His main interests include sudden cardiac deaths, syncope, and advanced electrophysiology, where he continues to make impactful contributions. Today, he will lead us through an engaging ECG quiz session titled ECG Challenge. Are you ready? Please join me in warmly welcome Dr. Kirti Divulweber.
Actually, it's a very good evening. Thank you, Madam, for these kind words of introduction. I sincerely extend my appreciation and thank you to the President of Sri Lanka College of Specialist Family Physicians, and especially word of thanks to my friend and batchmate, Dr. Prabhat Nanakara, Senior Registrar of Family Medicine, and giving me this opportunity to conduct this ECG questions in annual academic sessions of SLCSPF. So without further ado, as we are running a little behind the time, we'll get on with the presentation. So all of these, I will be presenting 8 ECGs, all of them
that I have come across in my clinical practice where I feel as family physician, you would be, encounter these type of ECG in your clinical practices, day-to-day practice. And some of these ECG you might find it little too complicated, but there's a reason that I've included these ECGs, so you will get to know these things and then properly recognizing them and timely referring these patients. And it's important to differentiate between what is normal and what is abnormal. And when you decide what is abnormal, then the time factor coming in, how quickly or how early a patient should be referred to a specialist. And so these ECGs will pique your interest, and we'll get on with it. So the first question, I'm sure you all can see the ECGs clearly. Anyone in the back, you should be able to see it clearly. So a 6-year-old child who came to the OPD with complaint of atypical chest pain, an ECG was taken. And so what are no other significant clinical history? So what are you, I presented 6 differential diagnoses, 5 answers. So the answer is number 4. Let me do a little bit of explanation. So if you carefully see this ECG, you can see the patient is having, this child ECG is demonstrating the P waves. And P waves is followed up by QRS complexes, and there is a slight variation in the rate that is called sinus arrhythmia, which is normal in children. And occasionally, you can see that the P wave are sort of merging very close to the QRS complexes. So, and even if it is happening, the QRS complexes remain narrow. So this is a one of the first differential diagnosis one would come to your mind would be that whether this is WPW syndrome. But in WPW syndrome, you would expect to see the white QRS complexes, which is not normally the case. And if you carefully follow, you can see that the QRS, sometimes the P waves like really get inside the QRS complex. So that's what is happening is this child is having sinus node functioning as normal, but at the same time in children, because of the dominant autonomic nervous system, as we know, the sinus node is influenced by the autonomic system, and the AV node is also influenced by the autonomic system. In children, sometimes the AV node itself can generate an electrical impulse on its own, even in the presence of the sinus node. So what you see is actually the technical term we call it isorhythmic AV dissociation. So atrias and ventricles are dissociated. Sinus node is firing on its own, and the AV node is firing on its own, and leading both P waves and QRS happening at the same time. So this is something physiologically seen in children. You don't need to be alarmed. So the child's presentation with chest pain has nothing to do with this ECG. So this is something you need to reassure the parents. You don't need to be panicked. So let's get on with a little bit of information. So AV dissociation, as we know, the heart is a four-chamber structure. It has a special wiring system. It has an impulse generator, which we normally the sinus node, and then you have the junction box or the AV node in the middle, and your conduction system to conduct the electrical impulses simultaneous to the both lower ventricles. And occasionally, when you have in normal circumstances, sinus node is the pacemaker, and the rest of the conduction system remains as a passive conductor of the impulse into the chambers, allowing both atrias and ventricles to be activated in sequential manner, and the ventricles are being activated at simultaneously. So we call it AV association and VV association. So occasionally the AV dissociation happens when the sinus node is not working properly. The rest of the conduction system, in order to sustain life, acquire the ability to fire on their own. And occasionally we see the conduction system below the AV node, bundle of his or the bundle branches, or even tissues in the ventricles, pathologically acquired ability to generate impulses on their own, superseding the AV node conduction. So that is one of the other occasions you would see the AV dissociation. The best example is ventricular tachycardia. So when the ventricles is beating faster, atrias are going on their own, leading to AV dissociation. The other example is a complete AV block. So the hierarchy of impulse generations, SA node is the dominant force, which normally gives a higher heart rate. And under normal circumstances, SA node receives the highest sympathetic and parasympathetic influences from the brain as compared to the rest of the conduction system. In the absence of AV node, sinus node disease proper function, the rest of the conduction system could get the ability to fire on their own, generating an impulse. So ready for the question 2? So there's a very interesting ECG. This patient apparently came to me after traveling 160 kilometers, seen by one of your, figuratively speaking, family physician saw this patient, 72-year-old female, presented with orthostatic or postural symptoms. The ECG was taken, which was found to be abnormal. Then the patient was referred to a physician, the physician referred the patient to a cardiologist, the cardiologist referred the patient to me. So, so these are the answers. So the answer is sinus rhythm with pseudobradycardia. Can anyone, not sure very clear, so what has actually happened in here? You could see that the ECG looks like it's bradycardic, QRS complex subile, there's a P wave, but what is striking is here, the most important piece of information, it was taken inadvertently at 50 millimeters per second sweep speed. So whoever the person was taking the ECG accidentally set the ECG machine at 50 millimeters per second. So the tape was running twice the speed it should be, and the QRS complexes are printed widely apart, giving rise to what we call pseudobradycardia. So the problem is we don't normally touch the patient. Nobody has checked the pulse, and unfortunately, so they were alarmed by the fact of the ECG and not paying attention to the technical detail, and that mistake had led the patient to travel 160 kilometers carrying this ECG. Unfortunately, nobody has checked the pulse. Had anyone checked the pulse, they would have realized that I wanted to highlight the importance of clinical, this we call symptoms ECG correlation. So whatever the investigation we have in our hand, make sure you do your clinical examination properly. So when you are interpreting an ECG, make sure that you place leads placement carefully and electrode quality for the accurate reading, and check the technical aspect, the calibration, and the sweep speed. So this kind of mistakes leads to unnecessary. So look at that patient has to travel 160 kilometers. The amount of cost that it has led to, with an unnecessary amount of stress and anxiety. So this type of little mistake, it'll add on to a significant economic burden as well. So that's why I took this ECG to show you, and make sure that when you are assessing a patient, the symptoms and ECG correlation should be established, and patient's details and and the symptoms at the time of the ECG was taken. So all these things matter when it comes to interpreting ECG. So this is a good lesson for every one of us. Yeah. Third question. So this is about a 74-year-old male who presented for cataract surgery, and an ECG was taken. And this is the ECG. So you have 5 answers. What do you think the correct answer is? This should be straightforward. The correct answer is number 4. So don't know whether you can appreciate it. So the P waves, and next P is conducted slightly slower than the previous one. Third P is conducted even slower than the previous one until 1 P is dropped. And the same cycle is keep on repeating. So this is called Wenke-Back phenomenon. So there are various type of AV block. So it leads to irregular rhythm. If you check the pulse will be regularly irregular as compared to atrial fibrillation. In atrial fibrillation, the pulse is irregularly irregular, whereas in Wenke-Back, it's regularly irregular. The sequence is repeating regular fashion. So get rid of the habit of saying heart block. It's a misnomer. You should not be, as professional, we should not be using this sort of misnomers. So make sure that you learn to use AV block. Okay? So there are various types of AV blocks. The first degree AV block, there should not be bradycardia unless the patient is having sinus bradycardia, because even though the conduction is slower, still one-to-one conduction is there. So as long as the sinus node is beating at the right speed, there should not be bradycardia. So the second degree AV block, there are several types where you would see occasionally P waves are missing. There's no distinct pattern as such, but the P waves are occasionally missed. And then you would see a fixed type AV block where at a ratio, the fixed ratio, the P waves are getting missed. And in complete AV block, A and V, the ventricles and atrials are completely dissociated. So there's no conduction in the middle, maybe no disc block, not conduction, but there is having a escape rhythm. So the ventricle rate is slow and fixed, and the atrial rate is going at their own speed, and there's no communication. The importance of recognizing AV block, even if they are not having any symptoms, make sure that you refer all the AV block patients to a cardiologist or electrophysiologist for the assessment, because AV blocks shorten the life expectancy. And even if they are asymptomatic, there is at least 10 to 15% of patients who are asymptomatic die suddenly with the AV block. I'll show you the reasons. So I don't know whether you can appreciate. So this is a patient with AV block, and the same patient, 2 ECGs taken at different times. So the first one is showing complete AV block with left bundle branch block configuration. The same patient, complete AV block with the right bundle branch configuration, the same patient. So where do we normally look at to identify bundle branch configuration? Is the lead V1. So V1, in here you can see it's a Q wave, and V6 is an R wave, whereas in this ECG, V1 has sort of RSR pattern. So these patients are sometimes asymptomatic, but this indicates their conduction system is very unstable and they can die suddenly, and this is how they die. These are real ECGs. You can appreciate the first ECG patient is in complete AV block with a very slow heart rate, developed polymorphic PT. So bradycardia increases the risk of ventricular tachyarrhythmias. It leads to QT prolongation, and some patients, they suddenly die. They suffer, they normally present like a fit because of the lead cardiac arrest, hypoxemia, they present like a fit. And that's one of the ways that they die. They develop. So this gentleman, develop polymorphic VT and degenerate into a VF. We were able to survive. This happened, witnessed cardiac arrest, so the patient survived. And this is the other scenario where you can see there's only P waves. The AV node, the escape rhythm suddenly stops, and there's only P. So that leads to, so learn these terms, it's called ventricular standstill. So ventricles are no contraction, it's a cardiac arrest. So all AV block patients, make sure that you get them referred timely. And if you see this scenario, you have to send them immediately, because this is like a time bomb. They can die anytime or suffer a cardiac arrest. So for the question 4, this is a 21-year-old female who presents with acute unprovoked palpitations and dizziness. ECG was taken. So you are given 5 answers. Try to pick up the correct answer. So, excellent. Yeah. So the answer is number 5, atrioventricular reentractcardia. So if you given this ECG, it was taken at 25 millimeters per second sweep speed and 10 millimeters per millivolt calibration. So it shows narrow, complex, regular tachycardia. And if you carefully see, don't know whether you can appreciate, if you look at V1, there's a slight notch just at the end of the QRS complex. We call it R prime. It's a very characteristic feature of when AV nodal reentry tachycardia. In AV nodal reentry tachycardia, where the AV node tissue has differentiated into 2 properties in terms of how fast they conduct and how quickly they recover. So leading to what we call reentry circuit, where the electricity travels in a circus manner, giving rise to rapid activation of both atrias and ventricles simultaneously. So this is a tachycardia ECG. You can appreciate that these arrows are showing the small notch at the end of this is normally very well seen on V1, lead V1. And then the same patient, if you can, see that compare, so make sure that when you have a tachycardia ECG and compare that ECG with the non-tachycardia ECG, you will get a lot of clues. Okay. So I'm comparing the same patients, non-tachycardia ECG V1 and tachycardia ECG V1. Since this is an SVT, the QRS complexes should look identical. But here you can appreciate that this notching is there's no notch in V1 in sinus rhythm, and that notch appears in tachycardia. So that is called the R prime. So that is the retrograde T of AVNRT. So when you see an narrow complex tachycardia on ECG, you can get multiple differential diagnoses, and so this is like, a detailed explanation, but recognizing a feature like this it's actually important. Yeah. So ready for the question 5. So another interesting ECG. The 85-year-old gentleman with multiple medical problems, with apparently having Parkinson's as well, and he came with atypical chest pain, and ECG was taken. So you have 5 answers. What do you think is the correct answer? So, yeah, looks like many people got the correct answer. It's actually the sinus rhythm with the artifact due to the tremor. So the patient was Parkinson's and having fine tremor, and it leads to, so muscle tremors means the muscles are contracting, non-cardiac tissues are contracting in a higher frequency, which was should not be picked up by the ECG machine, but occasionally it can be picked up by the ECG machine. So it was appear like, and to be honest, these people were very alarmed, and they have got the amiodarone ready, try to plan to shock and all kinds of things. And he was not having any. So it's another good lesson that when you see something on ECG, make sure that you do the correlate with the patient and try not to treat an investigation. Always the patients come first and the patient's details come first, and touch the patient and try to correlate ECG changes. This is especially true for ECG as well. So this ECG machine, or this is his normal rhythm. If you can see, the QRS complexes are going nicely, and in the middle this sharp deflection. No known tachycardia give rise to this type of sharp deflections. So this is not P waves, this is not flutter waves. This is the myopotential due to the tremor, which is being picked up by the ECG. So that is why even the previous slides which I explained to you, so make sure that you correlate your ECG with the patient, make sure that there are no other interfering factors, so the leads can be at fault, the patient's factors are contributing to the ECG changes. So make sure this is a good lesson that everyone needs to remember. So ready for the question 6. This patient who presented with, who brings a Holter report to you. The reason is his brother suffered a cardiac arrest and he's on ICD. So this tracing from the Holter is 24-hour ECG. So I took a snapshot of his Holter and give it to you. So you've given 5 answers. Great. So this brother suffered a cardiac arrest. Luckily, he's actually a medical student. The Holter belongs to a doctor. Suffered a cardiac arrest and he survived, and then he had an ICD then. So we wanted to screen the family. So as a part of it, we did the Holter for this gentleman. So this is the fact I want to highlight from giving this ECG. Now, premature ventricular complexes you would see often, and we tend to ignore it. And make sure that they are not innocent all the time. Okay? So if you see extra B to premature ventricular complexes, make sure that you take a good history, ask a family history, ask about the cardiovascular history, ask about history of palpitations, history of syncope, exercise intolerance, disease pulse, and anybody in the family had died suddenly and unexpectedly. So PVCs are not essentially innocent. So in this case, this is a condition called idiopathic ventricular fibrillation. These conditions are not so uncommon. You may have heard in news daily. You would hear a person had died running marathon, found dead on the bed. So scenario, these are not uncommon. So sudden cardiac death is not an uncommon problem. It's a very common problem, and we are missing clues most of the time. So this is what I want to put this ECG to highlight the importance of recognizing that PVCs can be really dangerous. So this is a short couple PVC. You can appreciate that these premature ventricular complexes is occurring right on top of the T wave, the R on T phenomena. So these patients, this gentleman was not symptomatic at all. And because of his brother suffered a cardiac arrest, and this became a very important thing. And he also received an ICD implant because he's at a very high risk of dying suddenly from cardiac arrest. So this is short couple PVC. And so PVC means premature ventricular complexes. We no longer call it as premature ventricular contraction. We call it premature ventricular complexes. So, and this is another real-time. Well, this is another gentleman. He had the same condition, and this is a tracing of a Holter, and the Holter has recorded he was developing polymorphic VT from the PVC. And he was in VF for nearly 2 minutes, and VF was settled on its own. And he was very, very lucky. They happened during sleep, and there wasn't much of a brain damage. Recognizing PVCs, do not ignore them. Ask a history, and if you feel there's something worrisome, refer them and get the echo done, get a 12 Holter scan done, and electrolytes. So there's a lot of work to be done when it's come to PVC. PVCs are a common problem, but they are not as innocent as one would think. Question 7. So this is a 19-year-old male who present with palpitation. What's the diagnosis? You have atrial fibrillation, polymorphic ventricular tachycardia, pre-excited atrial fibrillation with bundle branch block, ventricular fibrillation. Yeah, it's pre-excited atrial fibrillation. So WPW syndrome is not so uncommon. You would encounter one of their presentation, one of the dreaded presentation of WPW syndrome is pre-excited AF. That is where patients develop atrial fibrillation, and in a normal person, when they develop atrial fibrillation, the atrias are going at a rate of 400 to 600 beats. But as a fail-safe mechanism, the AV node doesn't allow fast conduction to go down. So they become slower. But when you have an additional circuit connecting the atrias and ventricle, like in WPW syndrome, atrial fibrillation goes very fast to the ventricles. And they present us as pre-excited atrial fibrillation, where the ECG looks very bizarre, irregular, fast rhythm. And that is how patients with WPW syndrome die. That's how they present with sudden cardiac death. So I wanted to highlight this. So if you see like a very bizarre ECG, one of the differential diagnosis that should come to your mind is, could this be pre-excited AF, where WPW syndrome has developed atrial fibrillation. And this atrial fibrillation can normally occurs in elderly people, but in patients who are with WPW, they can develop atrial fibrillation very early. So this is 19-year-old who presented with atrial fibrillation. So if you see patients with pre-excited ECGs or WPW, make sure that you get them assessed properly. So this is the same patient after having DC cardioversion. You can appreciate that the QRS complexes, the short PR interval with pre-excitation. So if you see WPW syndrome patients, make sure, even if they are asymptomatic, refer them. So we will assess their risk, and sometimes they become symptomatic at very unusual circumstances, and they should be properly assessed. This is just a slide for the acute management of AF, pre-excited AF. So this is the last question of the day. Something I wanted to highlight about a 65-year-old male with a history of ischemic heart disease and heart failure. So cardiac implantable electronic devices. I put this question to highlight the recognizing of correct terms. So those who are having pacemakers, ICDs, CRTs, so collectively we call them cardiac electronic implantable devices. So you would encounter in your practice many of these patients coming to you came with atypical chest pain, cough, and you took an ECG and an X-ray. So I'm asking, can you recognize the kind of device he's fitted with? It's a biventricular implantable cardioverter defibrillator. Don't know whether you can appreciate the ECG. Can you appreciate the QRS morphologies? You can see that the pacing spike and V1 is having a positive deflection. So biventricular means patient is having a right ventricular lead as well as a left ventricular lead. So cardiac resynchronization. The cardiac resynchronization is a device we implant for patients with heart failure and left bundle branch block. So you will come across these type of ECGs, and this X-ray, don't know whether you can appreciate it. This is the ICD lead, and this is the left ventricular lead which is in the coronary sinus, and this is the device. So you will, in your practice, you will come across patients like this carrying this ECG, and you need to get yourself familiar with these type of ECGs. So cardiac implantable electronic devices, so we collectively call for the pacemakers, ICDs, and CRTDs. So we have single chamber pacemakers where patient has a lead in either in the atria or the ventricle and a device. Then you have the dual chamber pacemakers where you have a lead in the right atrium and the right ventricle. And then you have advanced devices like ICDs. ICDs means implantable cardioverter defibrillator. Those devices are implanted for the patients who are at high risk of dying suddenly from ventricular tachyarrhythmias. And then you have the cardiac CRT, cardiac resynchronization devices, where patients present with heart failure and conduction system disease. So this is an ECG of a patient who had a single chamber pacemaker having a lead in the right atrium. So you can see the pacing spike in front of the P wave. And this is a patient who had a single chamber pacemaker and the lead is in the right ventricle. So you can see the QRS complexes with a pacing spike in front of. And this is the patient. You can see the device, this is an X-ray, and you have the right atrial lead and the right ventricular lead. So you have two pacing spikes, one each in front of a P wave and the other is in front of the QRS complex. And ICDs, where this is the ICD lead in the right ventricle, and they have a pacemaker device as well as the ICD function on the same device. So this is a dual chamber ICD where patient has an atrial lead and a ventricle lead. And this is a patient who are with a CRT device. So I put this because you will encounter these type of patients in your practice and you need to be familiar with the ECGs. That's all for now, and thank you very much. Have a good evening.
Thank you very much, Dr. Kirti Deulweva. It's with highly appreciation. With you have widened the knowledge in ECG for sure for the audience, and the common the scenarios that may encounter, even though it's the at once we see there's tertiary care, secondary care, but it's the primary care, the knowledge that we need to identify the problem as it is and to save the lives of our people. So thank you so much again for your wonderful the ECG presentation and the being inspires on giving your extraordinary knowledge. Thank you very much. Dr. Kirti Deulweva, you have to stay here to give you the token of appreciation, as well as we have the plan to provide the gifts for the 3 winners, top, second and the third, from your hands.
Thank you very much, sir, for conducting that quiz and the elaboration that you have given at the ECG Challenge Are You Ready quiz. And we have we saw the winners, the names are there, and the winners will be receiving valuable books courtesy of our Super Platinum sponsor, Morrison's PLC. And third place goes to Ms. MSF Shahnaz, Dr. MSF Shahnaz. answers out of 8 correct, and it's a matter of timing that differentiated the second place and the third place. Just 16 seconds. The second place goes to Dr. K.A.R.K. Karagala. And our winner is with 5 correct answers, Dr. Madhu. Congratulations to the winners, Dr. M.S.F. Shahnaz, Dr. K.A.R.K. Karagala and Dr. Madhu. And they are receiving a very valuable books courtesy of our Super Platinum sponsor, Morrison's PLC. And thank you very much, sir. And it is time that we recognize our speaker, Dr. Kirti B. Divulava, and I invite the chairperson, Dr. Malkanthi Galhena, to give away the token of appreciation and the certificate to Dr. Kirti B. Divulava, consultant cardiac electrophysiologist. So thank you very much, ladies and gentlemen, and that concludes the symposium number 5, and most of y'all are waiting for the poster presentations. And well, we had the introduction about the prize giving. It's about to give away the prize giving of the poster presentation. But before that, I would like to mention a few things about the session, because over the past few months, the abstract committee has worked tirelessly reviewing every submission, providing constructive feedback, guiding authors through revisions, and finally selecting the best abstracts and presentations that we had the privilege of witnessing today. The committee was headed by Dr. Asela Anthony, and with the invaluable support of the following distinguished members: Professor Kumara Mendis, Professor K. Arlanandam, Dr. Malkanthi Galhena, Dr. Niroshani De Silva, Dr. Aruni De Silva, Dr. Hirantini De Silva, Dr. Nayana Fernando, and Dr. Shalini Senaratge. And we also extend our gratitude to the judge panel led by Professor Atula Sumitipala and Professor Kumara Mendis, who assessed today's oral and poster presentations with academic rigor and fairness. On behalf of the organizing committee, I wish to place on record our deepest appreciation to Professor Atula Sumitipala, who completed his diploma in MD in Family Medicine at the University of Colombo and currently serves as a professor of psychiatry at Keele University, United Kingdom, emeritus professor of global mental health at King's College London, and founding director of the Institute for Research and Development in Sri Lanka. Professor Kumara Mendis, senior professor of family medicine and first person in Sri Lanka to obtain qualification in medical informatics, visiting consultant, Department of Community and Family Medicine, University of Mortua, conjoint associate professor, University of Western Sydney. And we also have Professor Kandasamy Arlanandam, professor in Family Medicine, Department of Primary Healthcare, Faculty of Healthcare Sciences, Eastern University, Sri Lanka. Dr. Asela Anthony, specialist in Family Medicine and senior lecturer, Department of Family Medicine, University of Colombo. Dr. Nayana Fernando, consultant community vision and senior lecturer, Faculty of Medicine, University of Mortua. Dr. Shalini Senaratge, specialist in Family Medicine and senior lecturer, Department of Family Medicine, Faculty of Medicine, University of Kelaniya. And your commitment and expertise have ensured that the scientific content presented here today is of the highest standard, and we are truly grateful, and we do not wish your hard work to go unnoticed. And now it is my great pleasure to invite Professor Atula Sumitipala, the head of our judge panel, onto the stage to share a few words and present the certificates and prizes to the winners.
Good evening, everybody. I am not going to take more than 2 minutes because I know all of you are waiting to go after a long day. It's a privilege and a pleasure to be here as one of your colleagues. Before I became a psychiatrist, actually I was one of the very few people who got the diploma in family medicine as well as MD in family medicine. So today we judge. It was a very, very close competition among everybody. The standard was very high, particularly the presentations, the slides, whether it was poster or otherwise, it was very good. One of the things I noticed, a lot of presentations were based on case studies and most were epidemiological work. So my plea to you is think about beyond epidemiology, interventions. Actually, I was so fascinated to see large numbers of family physicians here, because this was, I wouldn't call a dream. At that time, we were waiting to see this happening. So proud and so happy to be witnessing it right now. So think about doing more research, the whole spread, because you will see the first-hand clinical material as primary care physician. So with that note, I would like to distribute the prizes. I could have spoken longer about the quality, everything, but because of the time factor, I'll stop here. Thank you.
Thank you very much, sir. And we are moving on with the awards, and the best poster award is the first award. That is the best poster award goes to the study on association of overweight and obesity on the level of treatment and control of bronchial asthma among children attending ambulatory specialist pediatric clinics in public sector hospitals in the Gampaha district. It is done by Rupa Singha KS, D. Silva HL, and Mahesh PKB. The certificate will be received by Dr. Rupa Singha KS on behalf of the team. Congratulations, Dr. Rupa Singha KS, Dr. D. Silva HL, and Dr. Mahesh PKB for the Best Poster Award at the Annual Academic Sessions 2025 of Sri Lanka College of Specialist Family Physicians. Then we are moving on to the Best Presenter, and that is for the study on diabetic food screening audit in a primary care clinic in Sri Lanka. The best presenter is Dr. Marsh Muthuthambi. Congratulations to you, Dr. Marsh, for being the best presenter. And next we move on to the Best Research Award that goes to Insights into Compliance with Post-Exposure Anti-Rabies Vaccination in a State Sector Hospital in Sri Lanka. A retrospective analysis by Dr. Karagala, K-A-R-K, Dr. Nayanananda, GGTP, and the certificate will be received by Dr. Karagala, K-A-R-K. Congratulations to Dr. K-A-R-K Karagala and Dr. GGTP Nayanananda for winning the Best Research Award. Professor, please remain on stage, as it is time that we appreciate the judge panel, and to award the token of appreciation to the judge panel, we invite Dr. Malkanthi Galhena, our chairperson of the Scientific Congress, to come on stage and to give away these appreciations to our judge panel, starting from Professor Atula Sumitipala. Thank you very much, sir. And to Dr. Asela Anthony. Thank you, sir. Thank you very much. And to Dr. Shalini Senaradgay. Yeah. Thank you very much, Dr. Shalini, and thank you very much, Madam Malkanthi Galena. And before we conclude, there's another, there's a session where you're going to walk away with some prizes. It's a raffle draw, and I would like to invite the team from ATCO Laboratories to conduct the raffle draw, and also can I have the president here too, because it's going to be a technical raffle draw, so would like to press the button. Do you have Dr. Priyantha Halabarachige? Yes, sir? Yes, sir. All right, this is the first prize that we are about to draw. The first prize is actually the hotel stay at Aralia Unawatuna, either Aralia Red Nuaralia or Alia Resort Dambulla. So this is the first prize that we are about to draw. So as you could see, we have the name on the spinner, so please, sir.
Can I do it here? Right?
Yes, sir. Dr. M.V. Cross. Do we have Dr. M.V. Cross? He is the winner of the hotel stay. Yeah. So are we going to redraw, or are we going to announce the winner?
No, we'll
draw. We will redraw, because those who are here should be, have the... Yes. So we'll have to redraw. Remove. It's fair by all of you that those who are here, one of you here will be receiving the prize. Dr. Sandara Lahiruni Vaddanambi. Oh yes, she's here. Congratulations to you. So you win a hotel package of your choice from these three. Hotel stay at Aralia Unawatuna, Aralia Red Nuaralia, or Alia Resort Dambulla. Congratulations to Dr. Sandara Lahiruni Vaddanambi. Right, so it's the second prize. Now the second prize is a multifunction portable Bluetooth speaker. A multifunctional portable Bluetooth speaker. Let's see who the winner is. Dr. NPPH Jayawardena. Dr. NPPH Jayawardena. No? Okay. Calling once, twice, gone. We are going to redraw. remove, sir. Right. Okay, let us see. Let's keep our fingers crossed. Who's going to be the lucky winner? Dr. Tilanka Kasunjit. Congratulations, Dr. Tilanka Kasunjit. That's not a small speaker. There's one more prize to be given. So this is actually, you can remember that you all did a scan a QR code from John's Hills Properties, and then they have done the draw, and the winner stays at Cinnamon Life, night for 2 at Cinnamon Life. And the winner is Dr. Thilini Gunasekara. Congratulations, Dr. Thilini. Thank you very much, sir. And that concludes the awards and prizes and surprises. And ladies and gentlemen, it's time, as all good things must come to an end. And all right, there's another thing, the Slido quiz. Those who took the Slido quiz, every phone has received a feedback form. Please fill the feedback form and please send it back. So that's a request by the organizing committee. And now I invite to deliver the vote of thanks, Dr. Udanta Radgamage, the Secretary of Sri Lanka College of Specialized Family Physicians. Over to you, sir.
Distinguished guests, respected colleagues, and members of the faculty, and dear delegate, on behalf of the Scientific Committee and the Council of the Sri Lanka College of Specialist Family Physicians, I wish to sincerely thank all of you for making this annual academic session a success. We are deeply grateful to our faculty, both international and local, for sharing your valuable knowledge and experience. Your lectures and discussion have helped us learn, reflect, and grow together. A special word of thanks goes to the Chair of the Scientific Committee, Dr. Malkanthi Galhena, for her great commitment and leadership in preparing a program of high academic value. We are grateful to the President, Dr. Priyantha Halambarachi, and his council for the constant support and encouragement during their process. We also warmly appreciate the hard work of the organizing committee. Their careful planning and dedication made sure that everything went smoothly during this session. We are also thankful to our sponsors and partners whose kind support made this event possible. Most importantly, we thank you, the delegates. Your active participation, questions, and enthusiasm gave true meaning to this session and made them successful. With heartfelt gratitude, we conclude this annual academic session. We wish you all the very best and pleasant evening. Thank you.
Well, a big thank you goes out to you as well, sir, the Secretary of the College. And once again, thank you very much, ladies and gentlemen. It has been a very fruitful day, as well as a lot of prizes were won. And looking forward to see you all involved in the college activities in the coming days as well. Thank you very much, and God bless you all.